Good morning, ladies and gentlemen. We are now live. It is 10 o'clock on Monday, the 11th of July, 2022. Welcome to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. May I remind committee that today's meeting is being recorded, and for those people who want to watch it back, the session can be found on the County Council's website. The meeting is also being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in the chamber in person, and there is a variety of people in attendance as our guests. Can I thank our guests for their input so far, for the papers and for the opportunity to scrutinise the work that is on the agenda. Can I ask our presenters today that they restrict their opening comments to either 5 or 10 minutes, depending on whether we've seen the item before, as we're going to be tight on time, and I would like to ensure that every minute available is being used for scrutiny and evidence gathering. Second of all, can I encourage, and I say this every time, can I encourage committee to focus in on the tangible outcomes for the residents of Staffordshire, using the data and our experiences to sharpen the quality of debate and scrutiny so that we can provide assurance and reassurance that things within the health and care system in Staffordshire are going in the direction we would like to see for our residents. Before I move on to today's agenda, I'd just like to mention a couple of things in passing so that committee are fully up to speed. First of all, I would like to congratulate the NHS last Tuesday on their 74th birthday and crave committee's indulgence to cover the following elements. First of all, we would not be a functioning health committee if we did not mention during the hottest few days of the year the importance to people of hydrating appropriately and being careful because of the weather and ensuring they drink plenty of water. These are unusually high temperatures and they can be extremely dangerous for some in our communities. I would also encourage people to check on their friends and neighbours, especially those more vulnerable than themselves. Second of all, on the 1st of July 2022, the new NHS system architecture moved from being in shadow form into being a reality. That is the transition into an integrated care system. And no doubt, as part of the agenda, we will talk about that as we go. But first of all, I'd like to welcome the start of the integrated care system and hope that they will be strong champions to drive improvements to the long-term health and well-being of all Staffordshire's residents in the most efficient and effective way possible. I also wanted to record our thanks to the 6 clinical commissioning groups under the leadership of the Senior Responsible Officer, Marcus Warnes, and his executive team for all the work that they have done since their creation on the 1st of April 2013. These have been unprecedented times, and the work that has been done during that time has hopefully set us on a course to get the system to be financially stable and drive the health improvements we all want to see. Thirdly, back in February 19, there was a devastating fire at the George Bryant Centre in Tamworth, which had 2 wards providing assessment and treatment services for up to 31 adults and older adults with severe anxiety, with severe mental health issues and dementia, including mood disorders, psychosis, anxiety, and depression. The services were relocated to Stafford at the time, and they have come in front of committee a number of times to look at the way they would be re-provided for the services in the long term. Some concerns have been raised that the consultation and supporting business case has been circumnavigated, and I would just like to mention to committee that the George Bryant Centre is on committee's agenda for the August meeting on the 1st of August 2022, which is 3 weeks away, where we will be able to go into more detail about the business case and the process going forward for the long-term provision of services. I move my attention to the John Munro Group. The John Munro Group provided mental health and learning disability inpatient services to some of Staffordshire's most acute residents through their sites at Mitchell House, which was a care home, the John Munro Hospital and Edith Shaw Hospital, all located, I believe, within the Moorlands. The whole subject of inpatient services was discussed, if you remember, committee, in the autumn of last year. The business failed at the end of May, and members will remember that the care home had ongoing quality issues from those discussions back last year and through the CQC inspections. At the time of failure, they had 12 residents in hospital, with the CCGs responsible for their location, and 7 residents at Mitchell House, which was the responsibility of the County Council. I can confirm to committee that the relocation of residents was completed within 5 days of the issue arising, and those involved have been commended for their prompt and joint action with system partners. Furthermore, the out-of-area patients have been relocated, principally closer to home, and their respective lead commissioners will take forward oversight of their settlement into their new accommodation. Finally, before we go on to the agenda this morning, and apologies for the length of these, but you can see there's been quite a lot of work that's been going on in the background. Some members may be aware of a statement from West Midlands Ambulance Service that services will be stretched past breaking point by the middle of August 2022. We equally have the system, because the ambulance service is part of the wider health system from admission to discharge, on our agenda for September. And I certainly don't want to preempt those discussions. But I have sought assurance from the West Midlands Ambulance Service on whether services will still be available going forwards post the middle of August for our residents, and in summary, their Chief Executive, Anthony Marsh, has responded as follows. In the meantime, before committee, I want to take this opportunity to confirm to you that whilst the service is under very considerable pressure, our staff in our control rooms and our operational paramedic ambulance crews are working flat out to reach patients as quickly as possible. Please be assured the service will continue as normal despite these challenges. I will not allow this service to collapse. And those were the words of the Chief Executive, Anthony Marsh, Chief Executive of the West Midlands Ambulance Service. As I say, that is on our committee agenda for September. This assurance is important, and I have additionally written to the Regional Director of the West Midlands Ambulance Service to seek a similar assurance, and will circulate some data and documents to all committee members to provide greater substance behind these exchanges during tomorrow. One element outstanding is the wider scrutiny of West Midlands Ambulance Service, as just like it is not for districts and boroughs to scrutinise county matters, it is not for county to scrutinise regional or national NHS matters. In this case, West Midlands Ambulance Service provides services over 14 upper tier authorities, and I have asked for a coordinated approach to scrutinising the regional ambulance service from across the whole of the West Midlands. This is unique in its application and is taking some time to identify not only who the lead commissioner is, but also the relevant way of holding pan-county scrutiny of the West Midlands Ambulance Service. Apologies for the length of the opening comments, but believe you me, each one of those has serious implications for either some or all of our residents, and the fact that we can say many of them are diarised for scrutiny or have been positively resolved is positive, but shows the challenging times we were in for health and care at this moment. Can I thank everyone involved for working on the above? So let's move to the agenda, shall we? First of all, if gentlemen want to remove their jackets, please feel free. I'm not sure what the alternative for ladies are, so I will leave that where it sits, but please make sure you take the opportunity to drink plenty and that you are as cool and comfortable as possible. So, on to apologies. Des?
Yes, Chairman. We've received apologies from Councillors Philip Hewitt, Mike Wilcox and Julia Jessel. We have in attendance today Councillor Steve Norman, who will be substituting for Councillor Wilcox.
So, good morning and welcome to new members, which also includes Councillor Philippa Haddon. There you go, that's good. On to item number 2. Declarations of interest. Do we have any declarations of interest relevant to this morning's agenda? County Councillor Angela.
Thank you very much, Chairman, and good morning, everyone. Yes, I'd like to declare I'm a partner governor of the Midland Partnership Foundation Trust from the County Council.
Thank you. Bernard Peters.
Thank you, Chair. I'm a governor at UHDB, the local authority appointed governor.
Thank you, Bernard. Councillor Steve Norman.
It's a bit more of a clarification, if I could, please. Obviously, Councillor Atkins is here, and it's an opportunity after many years to perhaps ask through you, Chair, and this is nothing to do with you, as you are clearly a competent Chair, and I've seen that on YouTube and so on. But many years ago, the former leader of the council and his deputy, strangely enough now working for a scrutiny organisation, did say that in opposition, they did say that when they were in control, the opposition would chair scrutiny committees. And I just wondered through you, Chair, if I'm confused why that isn't the case here, even though I respect you greatly.
Okay. On the basis that we're on agenda item number 2, which is declarations of interest, I actually don't think that...
I'll raise it later in the agenda, Chair. Thank you.
I will continue to disallow it unless it's on the agenda.
Well, it's Nolan principles, important integrity, honesty, something good. Councillor Atkins has a chance to speak now on the record, if he wishes to do so.
Can I ask you, Councillor Norman, to restrict your comments to what's on the agenda, please? That is not on the agenda. I'm happy... I don't like being interrupted either, thank you. I would ask you not to interrupt me or this meeting. It is not acceptable. And I'm more than happy to have a conversation outside of this meeting, which is the appropriate way to do it. And if you had any significant concerns, they should have been raised in advance of the meeting. I'm not going to take any further on this discussion. I will, however, take Jill Hood on the basis that it is relating to declarations of interest.
It absolutely is, Chairman.
Thank you. Good morning.
You mentioned the Bryant Centre, Tamworth, and I just want to say, I know we're not covering it today, but I have had a very nice letter from Chris Pincher lobbying me about the actual centre, so I thought I should declare it now. Thank you, Chairman. I'm glad to hear everybody has.
I've found out something new, which is very useful, thank you. On that basis, I would propose to share with all committee the correspondence I've sent back to the relevant Member of Parliament and the information I have to date and updates as we go, providing everyone is satisfied with that as a proposed action. I'm more than happy if you want to join every meeting, but it may be just more efficient to summarise and share. Yeah. Are we all in agreement? Thank you. Right, so can we just confirm we're quorate? I can see plenty of members and smiling faces, so that's a good place to be, so I think we are.
Yes. Sorry, yes. Yes, Chair, we are quorate today.
On that basis, I'll move on to item number 3, which is the minutes. I would like to approve the minutes of the meeting of Monday the 30th of May. Can I ask if the minutes are a true and accurate record for those of you who were there? I have a proposer, I have a seconder. Are we in agreement? Plenty of nods, thank you. Let's move on. I'm reliably informed that all actions have been followed up and all information received to date has been circulated. So let me move on to item number 4, which is the Integrated Care System and Integrated Care Board update. I'm aware, Tracy, that you're going to lead on this in the absence of Peter Axon. I would ask committee to be sympathetic in that Peter is not with us today due to absence at short notice. So we are going to circulate to committee the presentation separately, but Tracy is going to restrict comments to a 5 minutes opening, please.
Thank you, Chair, and thank you, councillors. Yes, apologies for Peter today. He is poorly, so he's asked me just to draw attention to some of the points that are in the paper that has been circulated to you. So the Integrated Care Board, which along with the Integrated Care Partnership, forms the Integrated Care System, which came into being on the 1st of July. We had our first Integrated Care Board in public, held on the 1st of July in the afternoon, and you can view that on our website. In doing so, coming into being, we are responsible now for improving the health and care of the people of Staffordshire and Stoke-on-Trent, and have taken over the roles of commissioning and monitoring local health services that previously the CCGs used to do, the clinical commissioning groups. In April 2023, the Integrated Care Board will take on further duties, and that will be pharmacy commissioning, dental commissioning and optometry. We'll also take on some responsibilities for specialised commissioning, but that won't be until April next year. The Integrated Care Board has been appointed to, and in the papers there's the names of the people that are there as the executives, and there is non-executive appointments already been made. There are some engagement with partners that will sit on the board, and you can see how the local authorities are represented. And I can now say that we do have primary care representation on that board, in which you will no doubt have seen, Chair, probably been written to, is that of Paddy Hannigan and Jack Orr, but also the mental health providers will be Neil Carr and Buki from North Staff's Combined Healthcare. As far as the Integrated Care Partnership development, that will be a larger group that will meet, and we are looking now to that first meeting in late July or August. The committee papers will be available on the website, and that meeting will be in public. You'll also see in the paper that there are emerging portfolios on how we will be delivering our work, and we can provide further detail of that in the presentation that will be circulated to you. You'll have known from the previous white paper on integration that place is where everything really is going to be happening, and we have agreed that there'll be 2 places, and that will be mirroring the local authorities, as said in the Integrated Care white paper. Provider collaboratives is another way of how we will be delivering services and how things will start looking different in the delivery of the care we provide. The clinical and professional leadership is documented in the paper, but just finally what I'd like to draw your attention to is our working with people and community strategy, which went to the Integrated Care Board on the 1st of July, and it is an emerging strategy, and you can view that on our website. And we're going around talking to people about how we can be more it's okay. More representative of the communities that we serve. So once again, just apologies from Peter Axon. I'm happy to take questions. If I can answer them, I will. If not, I will get back to you later on, if that's okay.
Thank you, Tracy, and thank you for stepping into big shoes. Appreciate that. So, Charlotte Atkins.
Thank you, Chair. First of all, I mean, this is supposedly an integrated care board, but it seems to me to be very NHS heavy. There are a few local authority representatives on there, but the idea is to have integrated care between the NHS and social care. This seems to me, yet again, an NHS heavy body where the money will be largely within the NHS. And given that we have a crisis in social care in terms of both staffing and funding, how will the Integrated Care Board address those issues? That's the first question. And the second question is I see that from April 2023, you'll be taking over the dentistry. And given that we have a crisis in dentist supply at the moment, particularly NHS dentists, how is the Integrated Care Board preparing for taking over dentistry? I mean, you can't get an NHS dentist for love nor money if you're a new resident or you've been kicked off a list by an NHS dentist who's now decided to go private. Given that the overwhelming problem there is the nature of the NHS contract, what impact can the ICB board make on this really significant primary care problem? We focus very much on GPs, but we seem to forget that dentists have a huge impact on people's physical health and mental health.
Thank you, Chair. In terms of the dentistry, I can actually circulate how we are actually looking at taking over. There is work going on with NHS England, who currently commission those services, and I recognise what you're saying and the importance of actually good dental care. So I can't go into details today how we'll look at that, but I will circulate that because there is a programme of work that looks at how we'll be taking over those extra primary care services, but it's a point well recognised around dental care and the importance of it for people's physical and mental health, but I'll circulate that later, if that's okay. In terms of the Integrated Care Board, that's actually, it's set in statute what we need to have on the board. So it is an NHS organisation. It's the NHS Integrated Care Board. I think the Integrated Care Partnership, when you see the makeup of that, that's a lot wider, and it's the Integrated Care Partnership that will be setting the strategy of how we improve health and care for all the individuals of Staffordshire and Stoke-on-Trent. The Integrated Care Board is the statute formal body that commissions health services. So it'll be the Integrated Care Partnership will be the one that will be looking at how do we improve the health and care for people in Staffordshire.
Come back on that. I mean, clearly the other issue is funding, and funding is going to be very much skewed towards the NHS, and understanding that the NHS is impacted by inadequate or lacking social care. You know, what's the local ICB going to be doing to try and reverse that decline? Because obviously the impact of a social care sector which has not enough staff is that you'll get more people within the NHS sector and you'll have to cope with bed blocking and everything else. So what are the plans to try and resolve some of those issues? Because it is an issue now, it's not an issue for a couple of years hence.
Thank you. And what you'll have probably seen before, where we've used NHS money that we gave to the local authorities last year in order to help with recruitment to social care services. We've used the Better Care Fund previously, where we use NHS monies to work with local authorities. So there will be, under the Integrated Care Board, I think there is more opportunity for that to happen and increase. But you're right, it's right to recognise the impact social care does have on health and people being able to live in their own homes, or have a home that is not hospital. So it is recognised, and there are mechanisms to help do that. And we've started to do that more and more as we work through COVID and through that. But any of the particular details, I'd have to sort of get the financial chief officer to sort of give you the actual, how does that work?
Could we have those details?
Pardon?
Could we have those details?
Yeah, I'll talk to Paul Brown, the chief finance officer.
If you could, thank you.
Thank you. Into Debs, and then we'll circulate to the whole of committee. Can I just pick up a couple of things that I'll build on a couple of things that Charlotte's just raised. First of all, in terms of dentistry, I wonder whether it would be appropriate for us to diarise something in March for March's meeting, given that it would be ideal to understand what the plans are, but also to make sure that those plans are appropriate for our residents going forwards. Is committee in agreement with that proposal? Yes. Okay, thank you. I'm assuming that's okay with you, Charlotte. Yeah. So we will diarise that, and we will make sure the committee formulate the questions that we want responding to. Obviously, we want to look at the future, not necessarily the past. Second of all, Tracy, if I can just direct this your way. You talk about the ICB butting up against the ICS and understand that completely. Where's the visibility for the general public? Because it was difficult enough to navigate the 6 CCGs when they were there, and they were there for a long time. So given that this has only just come into place, is there somewhere that we could point people to get a better understanding of the new system?
Thank you, Chair. Currently, we're doing some roadshows. At the minute, they're virtually. We will be doing face-to-face ones out with the public to talk about the Integrated Care Board, how it works, what will be different. So they're going on at the moment, and you know, I'm more than happy to circulate the dates. I know people have already attended one. There was 55 people I think it was last Tuesday that attended. So we can do that. But also we've got our website. Thankfully, we've got one website, the Integrated Care Board, and we haven't got 6 like we had previously with the clinical commissioning groups. And the Integrated Care Board and the Integrated Care System websites actually link with each other. So if any member of the public wants to get a hold of us through the website, they can do. They will find what they need through there. And the website is in the papers as well.
That's really useful. I'm sure committee would really be pleased to see both the details of the future roadshows, so if they can attend. I'm sure that committee will want to circulate those round their own district and borough councillors, just to help with that. It's difficult to navigate enough as it is, but maybe a wider understanding of the system would be good for all our councillors, and it would be useful to see those website details as well to back up that, please. So thank you, Tracy. Thank you, Charlotte. Keith.
Thank you, Chair. Yes, interesting times, I think we can say, in terms of what's happening. My first question really is, obviously later in the meeting we're looking at the primary care access update, which comes from the 6 CCGs. So my first question really, before we go and scrutinise that, is are you taking on board what they have put forward as being something that might be the starting point from where you might then alter things and change things? So that's my first question. The second, and on other areas as well, I mean that was just an example. And then the other thing would really be, and I'm fairly, well, I wouldn't say excited, but I would like to try and find out a little bit more about what our role is going to be. I think Jeremy's already touched on this to some extent. How that is going to change what we are going to be scrutinising and the structure of how we try and scrutinise it. Particularly interested with others, I think, about the community aspect of what's going to be going on and how we can get through the partnership some idea of a bit more involvement in terms of how things are going and really the idea of us seeing how well things are going, that type of how all that's going to fit into the new portfolios and everything else. I know it's some time from here, but I hope with other updates in the future, some of those questions will come forward. But my main interest really is to see what we can do for our communities, perhaps through this particular health committee, but also for the district health committees as well, to try and, if possible, to try and it comes back to money, I know, but to fund what we're trying to do ourselves within our own communities, which is something, I went to some community care awards recently and things like that, and I do think that the NHS does need to get a bit more involved in all that side of things, and we mentioned social care as well. But anyway, I think that's enough to be getting on with. Thank you.
Thank you, Councillor. And you raise a good point. We need to work a lot closer with our district and borough councils as well in those local communities. And the strategy for people in communities, you can get a link to it in there. It does actually reference that within there. So that is something that we are looking to do, knowing that perhaps previously we've asked people to come to us when actually we need to go and work in those communities because that's where people are. They form their own communities and that's where we need to be. So that's the aim of the strategy going forward, how we do that. In terms of taking over the primary care access you mentioned, the Integrated Care Board has took on all the responsibilities that clinical commissioning groups had previously. So that work will continue, the campaigns will continue, the changes in access that Lynn will talk about later on the agenda will continue and we'll carry on with that work.
Thank you very much for that. Now, the other thing is how are we going to work within our structure? And certainly I think that some of us would probably want to try and get a little bit more involvement, but some more details on that, maybe a work stream between ourselves and yourselves and everything else. I know we're looking at the North Staffordshire arrangement at the moment as well, for hospitals as well. So that's sort of more integration. You know, I know that you may have a strategy, but it's really down to how that's going to be implemented and the speed of implementation, because I think there's a lot of willingness out there after the pandemic, but if we're not careful, we're going to lag it 2 or 3 years, and then there just won't be that interaction or engagement that we really want to try and push on at the moment. Thank you.
Thank you, and thank you for that, and we will take you up on that offer.
Thank you. Jenna Sylvester-Hall.
Thank you, Chair. One of the things that I wanted to raise you've already just covered, which was you've mentioned the website, but I think in terms of people who do watch the broadcast of these sessions, that we could be a little bit more specific as to what the website is. Clearly, there's going to be an awful lot of information that's going to be there, which is going to be able to be accessed by them. So I think as part of the engagement, some clarity on that might be helpful. The part that I was looking at as well originally, but you've also answered some of that, is the appointments that have been made for primary care and also mental health, which I was particularly pleased to see, that designated role, with every respect to my colleague, Councillor Edgeler, on that particular note. So I'm pleased to see that part. But knowing this date was coming, they were to be appointed, I just wondered what the process was that had been involved in that, and if there'd been any particular challenge in appointing those.
There's not been a particular challenge in appointing those, and the process is really laid out because we have a constitution that we have to adhere to, and it's laid out by NHS England. So there's quite a formal appointment process that we have to go through. So there was plenty of people who nominated through the partner ones. In terms of the executive, they were formal recruitment processes, as were the non-executive directors as well. So we followed that process. Absolutely can circulate the website details, and if you just put into Google Staffordshire Integrated Care Board, it'll come up anyway. So we've got the search engine optimization on that, so people don't have to sort of have the www. They can find that themselves. So hopefully that has answered your questions.
Thank you. Richard Cox.
Thank you, Chairman. I'm just referring to the report at 9, Working with People and Community Strategy. I've just tried to go onto the strategy to be viewed on your website, and the page isn't available, so it would be interesting to see what that is. So in the absence of that, at 9.2, I just wanted to see, in terms of the strengthen your approach by identifying gaps and finding ways to fill them to address inequalities. Are you able to elaborate on that today? And regarding 9.4, you refer to several face-to-face roadshows, which I welcome, but invariably, if these are during the day, actually don't reach out to the members of the public, and often evening roadshows might be more accessible to the public.
Okay, thank you, and apologies if the page isn't found. I can actually circulate the strategy anyway. It should be. I'll just make sure someone's onto that now. I'm sure they're actually in the background going, oh, where is it? But I'll make sure we circulate that because it's in the public domain anyway. So we shared that on the 1st of July. In terms of addressing inequalities, it's like what I said earlier. We've learnt quite a lot through the pandemic of how to reach different communities, and we need to build on that. You'll have seen the vaccination buzz going around communities, all sorts of different things that we've been doing. And like the councillor said previously, we do need to build on the work that we've learned through the pandemic. So we will be doing that because there's different ways that we can address them. Sometimes some of the most disadvantaged members of the public don't come forward to our usual roadshows or anything. We need to go to them. And we had to go to them with the vaccine. And so we've learned how we can get to those communities. The roadshows are not in the day. There's some in the day, but there was some in the evening. The virtual one that's tomorrow evening that I'll be on. So we do mix them around in terms of timing because you make a good point. People who are working can't actually join in. So we do some in the evenings, some in the day. We're just being careful with the face-to-face ones, making sure we're not bringing big, large groups together and being very safe and mindful in what we do.
Can I just, thank you, Richard. You didn't want to come back, did you? Richard? You didn't want to, can I just pick up the point about the strategy? Because there's a real danger we focus on the architecture of the NHS, not the outcomes. And I think Richard touches on this with his question about strategy. When will the strategy be nearly complete, having had input from partners? And do you feel that we should actually be focused more on scrutinising the strategy and the delivery plan underneath the strategy rather than the architecture which is nationally derived?
I'd be more than happy to come and present on the strategy and how we're taking things forward, how we're involving different members, how we're recruiting or nominating to the People and Communities Assembly that's part of the strategy. We have some statutory duties as an integrated care board to involve. And so that is, we have to have an architecture to do that with, but more than happy to come and present to you as we're working with the emerging strategy throughout the year.
Thank you, Tracy, and thank you, Richard, for that intervention. Bernard.
Thank you, Chair, and thank you for the story so far. Listening very carefully and looking at the report, I'm trying to get a sense of pace. Pace is important, of course, and you all know that. But I turned the page, as it were, and I was looking for some demonstrable milestones in terms of what's going to happen next. I don't get any of that from the paper that's been submitted today, unless I've missed it. So could you just play back to me an answer to those points, please?
Okay, thank you. So we have a transformation programme that's ongoing, and so we will continue with that. So some of the work that started with the clinical commissioning groups, you mentioned George Bryan Centre, Heather's talking about maternity services. So all that work that we had started will continue and continue at the pace that it needs to do. In terms of actually milestones within that, I can come back to you with the portfolio. So there's 7 portfolios that have just been agreed, and they're all sort of areas of work. And perhaps we need to just come back to you with the detail of those and what those work programmes are, because I think that's what makes the difference to the members of the public rather than the architecture of what the Integrated Care Board is like.
Chair, if I may, if we have nothing to measure or nothing to take a view on, it makes it a little arduous at times. Thank you. I'd welcome that information.
Is that something, Tracy, that could be circulated, over the next week or two? Does it have to wait until the strategies?
No, the 7 portfolios that are the agreed areas of work we can circulate now.
I think committee would welcome that. I think we've got everyone who's saying that. Bernard, anything else? Anne Edgeler.
Thank you, Tracy, for your presentation. My question really is about the people that use the health service an awful lot and that, but probably they're isolated, and especially the people with mental health problems. And how are you going to reach those people and explain the workings of the integrated care system, please? Because it's it's all right having road shows and that, and a lot of people probably don't use computers, so how are you going to get that message out to them, please? Thank you.
We've been working with voluntary sector colleagues as well to do that, people who actually work in the communities. We need to work through people that actually do have that engagement. We know that there's many organisations in the community and people in the community that work with people with isolation and who live in isolation. So we need to do more of that. Sometimes I don't think people are that interested in the architecture of the Integrated Care Board. They want to know what's different for me. What are you going to do that's different for me, that's going to make my life better? And so we have to focus on what the right message is and how we work with those people. So it'll be an ongoing challenge for us, but we need to work with those members of the communities that already reach those people. And like I said, we learned a lot through COVID and how we had to reach people, most vulnerable people as well, because they certainly through the vaccination programme, they really needed the vaccination, so we had to get into those communities. So we need to learn from that and keep learning, because we'll never always get it right, but it is something that we are committed to do.
Anne, anything further? Just on that, Tracy, I'm assuming that you'll also seek feedback to know that you've actually reached those people, and is there a role for Health Watch within that?
There is, and currently we commission Health Watch to do some of the work for us to actually reach certain communities. I think it's young men. There's 3 different areas we're looking at the moment, and Health Watch are actually doing that work for us, because sometimes they don't engage particularly well with the NHS, and working with other organisations actually makes it easier for them to engage. So we do that with Health Watch, yes.
Thank you. And bearing in mind Health Watch is on the agenda for later in the meeting, and I don't want to take that earlier, when we talk about integration, here's a good example of one organisation commissioning Health Watch to do one thing, and then another organisation, the County Council, commissioning Health Watch to do something else. And maybe we could encourage both partners to talk and see if there's greater alignment in commissioning terms, given that it's the same audience you're trying to reach at the end of the day. Maybe I'll just leave that as an open question on the table. Charlotte, did you want to come back?
I did, thank you, Chair. Tracy, you said that you've learned a lot from COVID, and you talked about vaccination. So I wondered why a town of over 20,000 people with an older population than most has not got a walk-in vaccination centre. We have a hospital in Leek, we have a fire station in Leek, and you're expecting people who don't have access to their own private transport to either travel to Mere, 10 miles, or to Milton, 6 miles. That is just the way, a perfect way, of discouraging people from taking up vaccination opportunities. So what are you going to be doing about it?
Thank you. I'll have to come back to you on that, whether Lynn might be able to answer that question later on, who's run the vaccination programme, or I'll come back to you on that issue. I think Lynn's come on screen, actually, so she might be able to answer that. Sorry, Lynn.
Lynn, we're with you. Good morning.
Thank you, Jeremy. Hello, everybody. Yes, I can answer that question. So we're still providing an evergreen offer for vaccinations across the summer and preparing for an autumn campaign. But what we have done is slow down the vaccination programme over the summer, because we have got fewer people coming forward, and it's about managing that vaccine appropriately. But what we are doing is putting pop-up vaccination walk-in sessions all over the county, and I haven't got the dates to hand, but we have got some walk-in session planned in Leek, and I'll be happy to share those dates and times. We will do a full communication around those as well.
Well, can you share those with me as soon as possible? Because what you're doing now is you're depleting the number of people who are going to come forward for vaccination in Leek because you're not providing an accessible location. So, you know, you're shooting yourselves in the foot.
Yeah, sure. It will be in Leek Hospital, so I'll get the date and time over to you, Charlotte.
Thank you. Well, we seem to have set a precedent. Angela.
Thank you very much, Chairman. Coming back to, excuse me, it's a request I made many times in this meeting, and probably a request to you, Tracy, for the integrated care system, that we put more information out about mental health and where to access help, because there's nothing, as I can see, in doctors' surgeries and that. So can I make a request that we do put more information out about mental health so people know where to access before they get into a crisis situation? Thank you.
Okay, thank you, Councillor. I'll look into that and we'll make sure that we do get the right access out.
Can I just suggest, given this has come up before, that we tie up with Lynn, because it came up at committee a couple of months ago. I'd hate to find we were duplicating work. But I do admire Councillor Edgler's persistence in this campaign. Just let me move on. I don't think anyone else is indicating. Let me just move on for a couple of questions from myself. The secret is in the title, integrated care. And one of the big issues within the NHS and within health and care at the moment is the flow of patients through hospitals. I referenced it when we talked about the West Midlands Ambulance Service. Will there be some tangible targets which partners sign up to, which will remove this as an issue, because it has been a perennial issue within the NHS pre-COVID and now post-COVID?
I'm not the chief delivery officer, and I'm sure if Phil Smith was here, he'd be able to answer you in chapter and verse, Chair. But it is something I can get. It's something that is well recognised, that the issue of flow through the hospitals, and it's something that we are continually looking at and reviewing, and that there's different exercises to say what does work, what doesn't work. And it's not just a local issue, it's an issue throughout the country. But I can get a proper answer to you from Phil, who's the Chief Delivery Officer, rather than me warbling on a bit.
Could never warble on, but I appreciate that, and I think that, you know, getting the people who are delivering that promise to make it would be useful. Just let me move on to another area, which is what are the bits in your view of the ICS that we should be scrutinising?
And the whole integrated care system. I think it'll be interesting to see what the integrated care partnership strategy, how that links with the Health and Wellbeing Board strategies as well, because that is going to be set in the overall ambition for health and care. So I'm sure that scrutiny members would want to see how that is developing.
Thank you. Very insightful. Thank you. Appreciate that. I'm not getting any further indications, so on that basis, Tracy, thank you for standing in at short notice, and thank you for your comments. I appreciate there's a number of things you're going to come back to us on. I won't list those now, but I think that committee focused really the discussion on the importance of communication and making sure that our residents understand where those linkages are, and we encourage all partners to maximise the benefits of those linkages. And equally, that I think there is a view from committee that we don't want to focus on the architecture. We'll assume that you will get that right because it'll be a national template, but we do want to focus in on the outcomes for our residents. But on that basis, Tracy, thank you for the presentation and the discussion in the papers. And on that basis, we will move on to the next item. Are you still with us? You're welcome to stay. Perfect. On that basis, let us hand over to Lynn, who is going to talk about primary care access, which is item number 5.
Thank you, Chair, and hello everybody. I'm Lynn Miller. I'm the Director of Primary Care and Medicines for Stafford and Stafford ICB, and I do apologise. This is an ICB presentation. We've got some crossover in terms of the CQC template that I've used, so that's my error. So it is around the ICB presentation and the action plan going forward. I've been to committee a number of times around access to provide reassurance of the plans we have in place, and previously talked about the 7-point plan that we've developed, the increases in demand that we've seen, and hopefully today I'll be able to give some assurance around the actions we've taken and the impact that's having in primary care. So what I will do is just pull out some of the key achievements over the last sort of 3 months, but also look at some of the data and focus on what our next steps are. So I think one of the things that's happened in general practice, and thank you for sharing that, that's happened is awful lot of transformation and change, and how jet practices work since the pandemic has been completely transformed. So if we could move on to the first slide. What we haven't done is communicated well enough what those changes are. And I think that caused quite a lot of noise in terms of people being triaged by receptionists and asked for information. New workforce that people just didn't know about, and they wanted to see a GP and couldn't see one. So I think we've learned from that, and we've developed, we've been working with the ICS People Plan panel to develop a campaign around our comms, and there's 5 key messages that we're putting out to the public, using lots of different mediums. So the 5 key messages are around the new ways of working, so how you might receive a face-to-face or a telephone appointment. We've done a lot of work around communicating care navigation. So people often feel quite aggrieved that a receptionist is asking the personal details, but obviously they're professionals, it's confidential, it's fully in confidence. And there is a series of triage questions that receptionists ask to be able to get to the patient, to the right healthcare professional. And on the back of that, we've appointed nearly 400 whole-time equivalent additional roles. So these are people like advanced nurse practitioners, pharmacists, urgent care practitioners, physios, who would probably be better suited for certain conditions. So, for example, some of the long-term conditions reviews may be carried out by a pharmacist who will understand the medication probably better than a lot of GPs. Or, for example, you might see a mental health practitioner rather than going to see your GP around that talking therapy. So we've got around 400 additional whole-time equivalents now compared to 12 months ago. And what we're doing is really promoting those new roles so people feel familiar and more comfortable with having an appointment with those roles rather than the GP or additional to the GP. We're promoting the NHS app as a way of being able to access patients' information, be able to look at your COVID vaccination status. If you haven't downloaded the app, I really would encourage you to do that. It's really easy to use. You can book appointments through there, and personally I think it's a very helpful tool that you will be benefit from. The final area, the key messages, is around the staff abuse. I've reported before quite the increase in acts of aggression towards staff, so we're really promoting that be kind approach with the patients, and hopefully that message will start coming through. Just picking up on Tracy's point about learning from vaccinations, we know that one size doesn't fit all, and we've built on the relationships we have with faith leaders, community leaders, to be able to promote our messages as well. So we're translating the information into lots of different languages, but actually asking the community leaders the best way to target their communities, and certainly we've got those relationships, and we're maintaining those in terms of other campaigns that we're doing, particularly around primary care. Just in terms of the digital programme, one of the things I think was a real bone of contention was the time people were waiting for, on the telephone. And back in July last year, we had particularly, we had 60% increase, 28% increase on activity in 1 month when we came out of lockdown, and waits were very long in some circumstances, and we know that was causing a lot of frustration. It was causing a lot of the anger. One of the things I hope people will notice when they call their GP is the different way of managing the telephone systems. So we're moving towards cloud-based telephony. So this is, patients won't see this on the ground, but certainly in practices, we're moving away those big old servers that people have, and it's all being done managed remotely in the cloud. It's certainly a lot more efficient way of managing telephone systems. But what I think people will notice is the advanced telephony solutions that we've put in place. So, for example, at times of high demand, patients are given the option for callback. They keep the place in the queue, and I've tested this out myself, so I know that it works, and the receptionist will call back at the same place that they were when they called, so they won't lose their place, and they'll be offered an appointment. And it really does take some of that stress and strain of sitting there waiting for the call to be answered. So hopefully people will have started to see that when they've run their own practices. Just in terms of digital, lots of capabilities that we've been adopting, we continue to build our digital capacity. I won't go through all of the details, but things like blood pressure monitoring at home, we've rolled out across the whole of the patch so people can manage their own conditions. So there's a lot going on there. I think in terms of quality and resilience, I think it was Councillor Edgeler was talking about mental health and wellbeing for patients, but we focus very much on our staff wellbeing. So 144 practices in Stafford and Stoke-on-Trent. Each practice doesn't have the capability to be able to roll out training and support packages. So we've been looking across the whole patch about how we can do that. And there's some real support, particularly for receptionists, that we've put in place. But one of the things that was fed back to me by the Stoke OSC, actually, when I presented a few months ago, was actually the two-way aggression, and there was quite a lot of reports that actually you could get into your practice a lot more easily now, but sometimes the approach of the receptionist staffs and the tone wasn't really where it needed to be, and it's probably contributed to some of the sort of frustration. So we've developed a package called Weathering the Storm, and it's really about, it's been about being the softer side of things, about being kinder, and supporting receptionists to take a step back, not just receptionists, all members of staff, and think about how their approach comes across on the patient as well. So we're really tackling some of the softer relationship side of things as well. We've done quality visits with all of our practices. We're working with those practices that have low face-to-face appointments and poorer access. So while we can see an overall improvement in access across the piece, what we do know is that it's not consistent. And there are some practices that are still not where we need them to be, particularly in terms of face-to-face appointments, for example. So we've got packages of support with those practices where we're supporting them to take forward action plans, and I can describe a bit about those. If we can move on to the next slide, this shows some of the data that we're recording. Our data monitoring of primary care is becoming a lot better now. There is an error in this report though, so we've had to pause some of the data monitoring while the systems are updated and moved into the ICB. So I've only got on here in March data, and it does say that the activity data is in line with 2019. If you look at the graph itself, it's actually significantly higher. So around 100,000 more appointments in March 2022 than there were in March 2019. So we continue to see that increased demand in the practices, but I feel it's been a lot more managed now. And you can see we're currently standing at 65% of practices being face-to-face, and that's probably the right balance, I would say. Awful lot of convenience around having a telephone appointment, so I think it's about balance, isn't it, and what's right for patients rather than having 100% face-to-face appointments, which I don't think people want to move back to. If we can move on to the final slides, I won't go through these in a lot of detail because it's in the pack and you can read those. I'm conscious there may be questions, but the next two slides really detail those 7-point plan areas and what our next steps are. So if I was going to draw anything out, we have our website live, which is Know Your GP Surgery on the ICS website. So please do have a look at that at your leisure and look at your individual practices. We're restarting the Access Improvement programme, working with NHS England, but really in the record keeping section, what I'll draw your attention to is the Access Support Package. This is the programme of work that's very targeted to those practices that are perhaps falling behind or struggling. And what this is a local scheme, so we've developed this in Staffordshire and Stoke. And the kind of things we're paying practices to do are patient surveys, so actually speak to their own patients. We know that relationships have suffered, so getting that feedback from their PPGs and patients. Mystery shoppers, the PPG groups, sort of testing their own practice out. The websites need to be up to date. We need to see an increase in the community pharmacy scheme, which I'll just come on to, improve data and an increase in face-to-face appointments. So that's the kind of package of support that we're putting in place around those poorly performing practices. If you just go to the next slide, there's one more thing I'd just like to pull out of the next steps plan. Obviously rolling out the digital programme still. It's in, so the quality variation, just to say, access isn't just about being able to get appointments. And one of the measures that we use is outcomes. So where we've got poor access, you often see poor outcomes. So we look at a whole range of information. We've got a full programme of work around quality improvement. The final point now I just want to draw out is around workload initiatives. So I touched on improving referrals into the community pharmacy consultation scheme. This is an opportunity for practices to divert patients from the care navigator, so from reception to community pharmacy, which may be a direct route to getting the service that they need. So things like UTIs, eye infections, minor ailments, insect bites could be rerouted to the local community pharmacy or be able to prescribe directly from the pharmacy rather than having to come to see the GP and then go back to the pharmacy. So we've got one of the highest referral rates in the West Midlands. We're being seen as a bit of a flagship, but it's another way that we're working differently with the wider primary care profession. And obviously, as Director of Primary Care, I've started to work very closely with NHS England on your dentistry and community pharmacy, and I think some of the resilience going forward will be how the professions work together in a more integrated way at network level. So I'll pause there, Chair, and I'm happy to take any questions.
Thank you, Lynn. As always, a lot of work and a lot of thought. Let me bring in Steve. Steve.
Thank you, Chair. Yeah, I mean, it's certainly very interesting and understandable. There's a lot of background links, as I see in most of these reports to this committee, a lot of work for members to do, and I'll certainly be looking at those over time as well, keep Councillor Wilcox on his toes when he's back from Cornwall. But I just wondered about the measures of the success of the progress of this. I just wondered if they were, reports would be coming back to this committee over time, or there are other ways of measuring that we can see on their websites and so on. So I just wonder about the progress of this excellent looking plan to me. Just only, I know it can be a pain, but just a very small anecdote there. When I remember when you could get your ticket from the GP surgery, go home, another village a few miles away, have your breakfast, get back again to save you waiting 2 hours to see the GP. Now you get the digital reminder on my surgery, and even before you've gone back to your car after having seen the GP, he sent you the link, or she sent you the link to a particular exercise from the website. I mean, it is just amazing now how much better it is than it used to be, and I look forward to this. I do have one specific question that just did rather stand out in the training and development on the last slide on item 6, which is financial well-being. And it says, we recognise that this is a difficult time for our NHS people. And we know the financial concerns have consistently been in the top 5 reasons our people call the free support helpline run by the Samaritans. And if you can expand a little bit on that, because that's rather a scary little sentence there, Chair. Thank you.
Over with you, Lynn.
Okay, thank you. Just in terms of the measures, I know Councillor Pert has focused on the evidence quite a lot in terms of how we're measuring what we do. One of the things that we've developed is a whole programme of work that's broader than just access, although it's all part of the same beast, isn't it? So things like our estates strategy, the digital strategy, our workforce plans, and we've got 12 domains of work that we're focusing on, and each one has got a metric that measures whether we're improving. So, for example, we've got a trajectory on additional roles that we aim to meet. We're currently below trajectory at 400 whole-time equivalents. We need to get to about 440 to fully consume the budget. But we've got a whole package of metrics now, and I'm happy to share those with the committee. And I think you'll find them quite interesting. And I think, we've listened to how do you know you're making those improvements, and I'm happy to share that, and you can see for yourself. In terms of financial well-being, what we've done is work with our practices to ask them what they need, so all of our staff, so not just our GPs, but people who are working on the ground in practices. We've done surveys with them to say what's important to them, to try and get a view to how we shape the programme. And what we want to do is recognise that we need some holistic support in place, and there's lots of different issues. So that was one of the things that was fed back to us by practice staff, that they're concerned around financial well-being. So it's just around a package of support we want to offer to all of our staff to ensure that they're in the best place they can be to be able to come and proactively engage in the workplace. So yeah, and we've obviously got the evidence base from the Samaritans. We talked to those around why do people call you, and that was the key theme that came out.
Thanks, Lynn. Steve?
No, that's a very full answer, and I'm very grateful for it. Thank you, Chair.
Just, thank you, Lynn. Just for visibility, we continue to work as committee on creating a KPI performance pack, which will be all enhancing, covering health and care. I've had a couple of meetings over recent weeks just to pull some more data together. Really keen that we try and create a pack that doesn't duplicate what everyone else is already doing within their ICSs, ICBs, or any other domain. So, but equally, I'm also keen that we don't create an industry in creating data that no one then looks at. So I think it picks up some of your point, but we would welcome seeing, Lynn, your data, because it will help feed into that broader discussion in terms of what it looks like. So happy just to see as a one-off the data you've got, and then we can have a further discussion from there. Bernard Peters.
Thank you, Chair. Thank you for the presentation. I heard you mention PPGs, but I'd wonder if you could build on that, please, because are they undervalued? Do you think you maximize the available skills that are in there? There is a wide variation in East Staffordshire, I'm aware of that, of how, if I could use the phrase, what a good PPG is. But the one I'm at, I won't mention which surgery I'm talking about at the moment, we're exceptional. We want to try and liaise with the doctors and all the professionals in the practice, and it's sometimes difficult to get access to them. Now, we see ourselves as a voice back into the community and would welcome some sort of enhancement to the relationship that we have with our GP practices. That's not to say that we're not working very hard to do that. So would you be able to give me a steer on the comments I've made?
Lynn, before we hand over back to you, patient participation groups for anyone watching live or watching the video back. Thank you. Lynn.
Thank you. I think that's a really good question, actually. And during COVID, the PPGs, patient participation groups, were actually stepped down as a national directive. So we had a period where practices didn't engage with their patients because obviously we were during the pandemic. We're in the process of stepping those back up now. Most practices have an active PPG that's very engaged with their practice staff. I think there is, I talk about variation. There are some practices that don't have them, but these are in the minority. One of the developments that we want to build on, though, is how we look at perhaps networks of PPGs. So currently our practices work at networks, and we've got a number of areas that have their own practice PPGs, but also have primary care network, PCN PPGs as well, where the groups work together, build resilience, share ideas, shape the PCN development. We've got one of our PCNs that's actually chaired by the PCN chair. I'm losing lots of acronyms, so I do apologise. But yeah, I think it's not consistently available across all of our practices, and we need to build on the strength of cooperation that we have for people giving up their time. We saw in the pandemic people coming forward and actively helping primary care to deliver the vaccination programme. So huge resource that we're very grateful for, and we need to listen. So I think we've got a bit more to do with that, and I think it links in with the ICB engagement strategy as well.
Just picking up on that, and I know Bernard doesn't want to come back, but just picking up on the point about reinvigorating and recruitment to your patient participation groups, Lynn. Often many of the councillors at district and borough and at county level are local community champions and have that network. I wonder whether those vacancies could be circulated to the local district, borough or county councillor, just in case they could provide either a name or alternatively additional services to those.
Yes, thank you for that suggestion. What I'm thinking of as well on the back of this, looking at our access plan, patient participation groups are not part of the plan as it currently stands, and that's probably an omission, actually. So as an action, I will take it back to the team to actually start developing a programme of work around PPGs as well, and picking up on your point around circulating any vacancies that are there.
Thank you, most useful. Keith Flander.
Thank you, Chair. Yeah, mine's just a very simple question, really, in terms of, I see back at the beginning of the whole thing, there's the idea of people trying to get to know their own surgery. I am somewhat, whether I've missed it somewhere along there, but how are you going to try and get non-targeted, sort of what I refer to as normal, relatively healthy people to get to know their surgery and the services they do? I realise that there's lots of integration with people that are probably in dire need of services, but hopefully it's the majority of the population who are still fairly healthy, and we've fought off COVID and all the rest of it. And I realise that these plans are going to go into the new portfolio structure that's going to be happening elsewhere. But I do think there's a bit of a hole in it in terms of how do you integrate normal people who are working during the day, the practices are closed in the evenings, how do you get them to know? I mean, I dare say there's lots of information online and all the rest of it, but I do think that potentially if people knew that they didn't have to contact the surgery to go and get a certain particular thing, or they could go to the pharmacy or could do things, but there does seem to be a very wide variation. And just going back, I know Bernard probably on this as well, but someone who's an active diabetic doesn't really know much about things. The doctor's surgery really just say, I'm just going to test you once a year, go away. And if you want to try and do better than you are doing at the moment, there's these groups that we don't know where they are. I mean, I think the one nearest to me was the other side of Burton somewhere, you know, which I couldn't get to and all the rest of it. So I do think there's an awful lot of things that still don't add up and still don't rate and actually result in an awful lot more people phoning into surgeries and asking for things because they just don't have the information necessarily in one simple place. I know it's not difficult. I realise it's quite difficult to try and get everything into one place, but it would be something that I think that the GP practices themselves and perhaps members of this own committee and everything else would be much better to know what's actually within all our communities, so that we don't have to keep adding to this everlasting list of things, and the people that really need the services can get through, and those others can sort of help and you know, go their own way maybe and access the services separately.
That's a good question. It comes back to the 5 key messages that we've developed, really, the key things that we want people to know about how to access alternative services, for example. So I've talked in the beginning of the presentation around how we're working with different groups to do things differently, but some of this is about arming practices with the information, consistent information. So we've developed primary care packs with the key messages consistently explained, and to actually, you know, use their social media channels. All practices are on Facebook now, so you know, using different ways of speaking to, communicating with patients. So not just putting the posters up in libraries and at public places, but using their own social media. But I think you raised a good question on how we target normal people, if that's the right phrase. And they are probably more tricky because they don't access services regularly. So I think that's a fair point. But we are looking at different mechanisms to be able to engage with different groups, be it age, faith, community, so we can get those messages out there. But we're sticking to the 5 themes, so we're not overwhelming people with information too.
Can I just come back on young people in particular and apps and things like that? I still think there's a long way to go on that to get them to start understanding it. My son's a student. He went to Birmingham, for example. He couldn't access surgeries there. He had to try and access the one back home again. He was there for first year. There was a complete muck up. And basically he just kept going through phone calls for about 5 seconds and getting released some antibiotics, which just didn't do anything at all. And really it would have just taken 1 5-minute chat with someone that knew what was going on, rather than, you know, it just leaving in no, you know, he's relatively fit, he just needed to get rid of this infection, you know, and it just took 9 months instead of 3 weeks. You know, it's just, it's not, in some respects, I just don't still see it working in the way that it perhaps should do in a modern world, you know. That's it really. It's educating others, I think, is something we all have to try and do ourselves, educate ourselves. But there is a way of being able to do it, and I think it just needs to be done slightly better than it is at the moment. Thank you.
Can I just pick up that point, Lynn? Were you going to say anything, Lynn? Sorry,
I was thinking about that really. Again, you know, a helpful suggestion of, it's slightly different in Staffordshire. So we've got at Keele University, for example, we've got a practice on Keele. So all students largely register there for the period they're at university. And likewise, we've got a link practice in Staffordshire for Staffordshire universities as well, where students usually register. So I was just thinking through the question really about how we could do it better. But again, I think, you know, looking at the way that we've managed the vaccination programme, we had to target different age groups, different cohorts in a different way. And Tracy's, I don't know if Tracy's here now, but she did, you know, we had to completely adapt our comms approach for different age groups, and it's something we should probably think about for the access programme. So I'll think about it. That's why I was looking with my brain whirring there, Councillor.
Thanks, Lynn. Can I just build on Keith's points in terms of where he was going to? I think his point about non-users and how do you engage with them. I think there is a point about how do you persuade them to access early and to raise concerns early. You know, I think particularly, and I'm just going to be very careful on what I say, I think particularly about certain males are very slow to respond to things. And actually, if we're going to move to a preventative agenda, then we do need to get the front door right. So I think it's a really useful point that's made. The second element is about routes to advice. Because in the end, the GP is not the only route to raising concerns or advice. And maybe we need to look at what are the pathways to getting support rather than just seeing the GP as the only way. Because after all, there is 111, there's community pharmacies, you know, you will tell me a whole range of other ones, and maybe we need to look at the prism from the other end of the telescope.
I think you're absolutely right. And I think in terms of the early intervention piece, I think that's one of the key priorities for the ICS going forward, the integrated care system. In terms of that quadruple aim is around how do we target individuals earlier, and it's a bit about my point that access isn't just about an appointment, it's about better outcomes. So I think you'll see that the ICS focuses on that as part of the strategy going forward.
Thank you, Lynn. Angela.
Thank you very much, Chairman, and thank you for that, Lynn, and the information. I mean, it's not a question, just a couple of comments, actually. I mean, I'm a member of the participation group with my borough hat on, and I find it very useful, actually. But just a nucleus of 3 doctors' surgeries in that. But on a wider scale, and the one that I'm a patient at, and I won't mention any names, I had a letter a few months ago, actually, about them being part of the big organisation and becoming a member of the NHS Trust in Stoke, you know, the UHNM. And I found with that I actually got an appointment on a Sunday morning. I was, you know, taken back by it, and I thought that was really useful. So, you know, in the grand scheme of things are moving forward, and I find that very interesting. And thank you for that, Lynn. Yeah, I just wanted to make those comments. Thank you.
Thank you. And we do offer 7 days a week, 8 till 8 services now. Not 8 till 8 at the weekend, but do cover the 7 days. So that's really good you've got that experience.
Thank you, Lynn. So I'm just going to take, I was going to take Chair's prerogative, but obviously ladies first. Janice.
Yeah, Chair, thanks for that. I wasn't sure if you'd seen me indicate earlier on, actually. That's why I was waving again. Lynn, if I could just have a couple of clarifications for me, please. With regards to booking appointments on the app, is that now consistently available? Is the first question. If it isn't consistently, is there a time frame when it is? And I received information recently about how there's some very clever residents, patients who have figured out how to also work with the telephony systems in their favour. So it's looking at how is that now being rolled out, is that consistent? So the callback opportunity is available. And then a third question, if I may, if we are looking at doing the bookings on the app and things like that, and I know I've asked previously, and you mentioned about the GP dashboard, but there's an awful lot of metrics that's gathered. How we can actually then share those as well with patients so that we know that there's 600 appointments that haven't been attended this week. And you receive some of that powerful information when you're actually in the surgery, but I think if there was more visibility of that, now I don't want to detract resource by being able to create that, but I do think some of that information is particularly powerful, but not necessarily widely communicated. And the onus is on both. You know, if we're making appointments, and especially if we're doing those on the app, are we actually still going to use those? Thank you.
Okay. Thank you. So the booking on the app is not consistent. All the practices run different appointment booking systems, but what we are doing is working with the practices over the next 12 months to make it more consistent. So same number of appointments being available, the same process that sit behind them. So that's a piece of work in train, and I do acknowledge that. In terms of the callback facility, I've not heard that anybody's been gaming the telephony system, if that's the case. So it trips in at peak periods when they're busy, and as I said, you get the opportunity for a call back and stay in the same place. If you see, we've rolled this out to a number of practices across Staffordshire and Stoke. The July actions are to roll the advanced telephony to all of our practices over the next 12 months. So the benefits of the system to the practice are huge. It gets a really positive feedback. So it will speak for itself. Practices will want to take this up because it's such a good system, and already the levels of abuse are starting to come down and people feel more comfortable, and it's really working. In terms of the metrics, do not attends, DNAs, isn't one that we actually use. We've got a really low level of do not attends in Staffordshire. It's between 3 and 4%, I think. That's in line, probably lower than most other appointments. And we also find it has an adverse effect that people actually think, well, other people don't attend, so why would I bother? So it's not something that we major on in terms of the DNA rates being a measure, an outcome measure, if you like. So we have talked about using that as a key metric in our report, but it's not one that we're using.
Janice?
Yeah, thank you. I think some of that was looking in the future as well. So if we're making lots of different opportunities available to make appointments, such as using the app, was that the concern was looking in the future that people then would book them in an anticipation, but then not use them. So, it's looking at and making sure that that information is available and communicated if it is necessary to do so. But no, that's great. Thank you for that.
That is helpful, actually. And what we need to be looking at DNA rates for the additional roles and whether we're seeing a differential with the booking mechanism. So actually we could look at that going forward. So thank you.
Thank you, Lynn. And just to pick up Janice's last point, I think we've been very clear on the view, which is it'd be good to get to a consistent patient journey for Staffordshire residents. I think that message probably couldn't be louder and clearer. And I think Janice's question picks that up. And I accept that they're all individual businesses, but at the same stage, we have to give a consistent offer to Staffordshire residents. Otherwise, it's highly confusing. There are enough pathways to navigate as it is, without having to have variations in the navigation of those confusing pathways. Let me just raise a couple of questions, if I can. First of all, if I look at the comment on which relates to the graphs, which says year-on-year comparison shows appointment activity, April 22 is in line with April 19. And funny enough, I'd done the maths based on the chart, and I'd made the same assessment of that as well. But what the difference between the 2 years is, there is significantly greater use of telephone appointments. Yeah. So what that seems to infer is that there is no additional capacity created by the move to telephone. That's what it seems to suggest to me. Just let me make all the points, and then I'll leave you to come back on the various ones. And the question I've got is, how are we going to create, or how are you guys going to create capacity to remove the backlog in being able to see a GP? Second point, we talked last time around at committee about GP access being busted, not because of the pandemic, but way before the pandemic. And I think most people accepted that. And that there was work going on a new model of care, particularly from a GP point of view, given that 90% of patients access health services through their GP first. So where are we up to with the development of that new model? And thirdly, recruitment and retention of staff within the NHS and social care is a critical issue, goes across every strand of activity. And I'm somewhat surprised not to see a greater chunk of that point about recruitment and retention and creating careers for people right the way from cradle to grave, or maybe not cradle, but you know what I mean. And maybe that's entwined in the ICS and not part of this plan, but I'd just be interested to see what that looks like, please.
really actually helpful questions there. So telephony is not necessarily more quicker. It's not necessarily a more efficient way of managing the time. This still requires referrals to be sent, tasks to be completed following the telephone appointments. So it's more about, we're moving to it rather than being convenient for the practitioner, being more convenient for the patient. So you're absolutely spot on. It's not a way of seeing more patients. It's just a different way of seeing patients. In terms of the backlog for the pandemic, the largest area that I believe there's a backlog is around our long-term conditions management, people not coming forward for the reviews, people not being diagnosed during the pandemic. So we've developed a programme of work around catching up, if you like. So a bit in the same way as the planned care programme is looking at electives, we're looking at how we can make sure that all of our patients who need to be managed, reviewed, who's got a long-term condition is where it should be. So we are front-loading something called the Quality Improvement Framework. It's a local incentive scheme that targets each practice to bring forward any patient reviews, identify any undiagnosed members of their practice before winter. So we want to do this, we want to accelerate the backlog management by September in the first 6 months of the year. So we don't go into the winter with lots of undiagnosed respiratory and unmanaged respiratory disease, for example. What we're probably talking about in terms of the new model of care is the strategy. So previously, and in the last 3 or 4 years, I've been focusing on primary care at scale. So about 5 years ago, when I took over Staffordshire, we had 167 practices. We've now got 144 practices, and that's by no accident. That's about merging practices, removing contracts in some cases, but working with practices to become bigger. The average list size now is around 9,000 compared to 6,500 5 years ago. So we've been growing, well, we've been optimising the practice footprint with larger practices, and we've found that that's a supportive resilience. We've also developed the primary care networks, so practices working together to be able to provide services. And you can see from the vaccination programme, that's how we delivered COVID vaccinations on a network scale. But it's more than just the networks working together, it's a planning footprint. So we've developed something called the Universal Offer. It's a series of 15 services that are commissioned across 100% of the practice population. So the Universal Offer means everybody has the same access and same level of access to services, a bit of that consistency point. So, for example, this may be things like anticoagulation monitoring. We know that every PCN, all practices in a given PCN can access anticoagulation monitoring, be it through the GP or through the network. What I think needs to happen going into the ICB is a refresh of this strategy. So, as you say, practices are independent voices. What we want to get them to a point is that they develop their own strategy for the future of primary care with a consistent voice. So I've established something called the Primary Care Collaborative, which will be a group of senior leaders across the whole of the patch that will start shaping that strategy. And that will very much be part of the work of the ICB going forward. Within that strategy, I think you're absolutely right, workforce will be a key element. We've got one of the lowest GP hold times, or the highest reduction in GP hold times in the Midlands, 7% reduction in GPs. And the question is why? Why are we losing GPs more quickly than anywhere else? And it's more than just about the workplace. There's other dynamics that we need to look at. And there will be a workforce plan as part of that, but it needs to fit into that bigger system work. Certainly with, working with local authority as well around education, bringing people into the NHS and growing our own workforce.
Thank you, Lynn. As ever, when you think you understand something, you recognise this is like an onion, and there are many, many layers to it. Lynn, on that point, we would like, I think, I'm just going to wait and see if I can see any nods. I think we would like to invite you back again just to review the plan. This is an iterative process. It is one of the key concerns of our residents and one we are keen to help support you and colleagues to get right. And so I would guess that we'll probably invite you back in 3 or 4 months if that's okay with you.
Absolutely fine.
Okay.
Great. Thank you.
Thank you, Lynn. Thank you for your input this morning. Appreciate that, and thank you for the work that you and GPs are doing. On that basis, let us move. You're welcome to stay or to go. Let us move on to item number 6, maternity services. Heather, I think you are leading on this.
I am indeed. Thank you, Chair, and good morning, everybody. Just to confirm, I've got Ali Budd with me. I think you've all met before as well. For anybody who doesn't know me, I'm Heather Johnston. I'm the Chief Nursing and Therapies Officer for the newly formed ITB, which I know Tracy and others have very capably briefed you on this morning. So without further ado, I'm going to do a very quick run through, a quick introduction, and then Ali's going to skip through the slides very, very quickly so that we can allow time for questions. So a bit of a double act for us. And like the previous item on primary care, we are also part of a big onion. So I'm sure we'll have some interesting discussion. As you know, I think I've previously attended to brief on maternity services, on changes linked to the pandemic and longer term, and the wider maternity transformation plan. And I'm sure members are all aware that maternity services used by our families are offered across the county in a number of locations, and that some of our patients also go outside of our county boundaries, so right outside of Stafford and Stoke-on-Trent, to access services closer to home. And when we do our work on the maternity transformation programme and everything that we talk about today, whilst our main focus is around Staffordshire and Stoke-on-Trent, we will and do factor in those patients that do travel to other areas. There have been, as you know, significant changes and challenges associated primarily with the pressures linked to the COVID-19 pandemic, and they've not gone away. And of course, recent numbers mean that we're still dealing with those pressures. And whilst all of this has been going on, Donna Ockenden has completed and of course published her report into the failings at the Shropshire and Telford Hospital. So there's a fairly active piece of work going on at the moment around the whole maternity agenda, and we'll talk a little bit more about that in a minute. Just one final point before I hand over to Ali and the slides, which I know you've all seen, so hopefully had a chance to read. Just to illustrate the point that Tracy made earlier about portfolios, if it helps at all, one of those portfolios is children, young people and maternity. And I am the executive lead for the ITB for that portfolio. And I'm sure as you start to meet more and more people who are part of the ITB, that will be the same for those. So without further ado, after that quick canter through my introduction, I'm going to hand over to Ali to give you the headlines from the slides. Thanks, Ali. Thank you.
Thanks, Heather. Hi, everybody. I'm Ali Budd. I'm the lead midwife in our local maternity and neonatal system. I know you've had the slides, and Claire, I think you're operating them, aren't you? So the first 6 slides really just cover what Heather's just talked about and gives you a little bit more detail. So what I'll do is I'll just flick to slide 7, if that's okay, because then I can I'll leave us more time for questions at the end, because I'm sure you'll have lots of questions. So slide 7 is about our vision, and our vision, it remains the same. And the aim of that vision is to implement the clinical model that we've got proposed on this slide. And this clinical model was worked on before the pandemic. We did some engagement work with our families of Staffordshire and staff and providers of Staffordshire. And this was the preferred clinical model. And that very much remains at the heart of everything that we're doing. Wrapped up around that is continuity of care, which is the next slide, please. And that continuity of care model is a national ambition, and that really provides the framework that will support us to implement the clinical model, which is around us having the choices that we've got already, but also our freestanding birth units to be running more of an on-demand model, which would be supported by continuity of care. So we've got another slide. The next slide talks about the choices. Just flick onto that. It just talks about the choices. I think it's just important to point out that the choice around freestanding birth units and home births is very much around low risk pregnancy. So anybody that's more complex, that choice is more limited, because obviously you need to be in a more specialised unit, which would be a consultant unit. So that's what that slide's describing. But I think the important reason why we're here today is to talk about our freestanding birth units, which are currently still suspended for births, although we are operating obviously antenatal and postnatal care from there with our community midwifery services. Both of our freestanding units are still closed. So if we go on to the next slide, we are working with both providers who operate the freestanding birth units, and they're both at a slightly different position in terms of staffing and being able to open up in that on-demand model. So UHDB, who operate Burton, and Samuel Johnson are hoping that by the end of this year they'll be in a position to have that on-demand unit opening up. UHNM are a little bit further behind. They've been having to do some more in-depth work around their staffing to get a kind of a benchmark on their staffing position alongside Birth Rate Plus, which is the assessment that they use to look at their staffing. And that's we've now got that report, so hopefully we'll have a better idea of how soon we can open the unit at Stafford. So that talks a bit about that. And then the last slide, if we just go on to that just gives you a little bit more detail around what the on-demand model is. We've talked about this before when we've been to see you, and I'm happy to take questions on that if you want me to. So happy to take questions. Gives you a little bit more time to talk about things.
Thank you, Heather.
Thanks, Chair. That's it for us in terms of presentation. Just happy to pick up questions, and apologies for the interruption.
Thank you, Alice, and thank you, Heather. That's appreciated. I'm going to start with Charlotte Atkins.
Yeah, you're talking about midwife shortages and being exacerbated by COVID, but what was the shortage of midwives prior to COVID, and how does that compare now? Because we are talking about a national shortage, and that's not really surprising when real pay has been cut over the last 10 years for midwives. So I would like to know what the figures were prior to COVID and what the figures are now in terms of the numbers that you're short in terms of the establishment you would expect to have at this stage.
Alison, with you.
Do you want me to come in for that, Heather? Yeah. So both UHNM and UHDB. So the reason why it feels different since the pandemic is because we didn't have the Ockenden report before the pandemic, which what that Ockenden report's done is it's shined the light on staffing in maternity. So maternity services were working to assessments that had been done by Birth Rate Plus without the context of Ockenden, continuity of care, some of the drivers for change and improvement. Since the pandemic, all of our maternity services are reassessing their staffing levels. So vacancies that they had beforehand that are part of their establishments have been reviewed and recognised that they need increasing. So that's where we've created the big gap of midwife shortages. So both our providers are reporting about 30 to 40 whole-time equivalent gap in clinical midwives at the moment, and that's based on the fact that they've had the uplift in their establishments to improve the safety. All of our universities, and obviously there's a national programme with Health Education England that are looking at how we then bring midwives up through their training and into our services, and it's more like a paint of the fourth road bridge, because obviously we've got newly qualified midwives coming in and midwives leaving at the end. So it's a 3 to 5 year programme to get maternity services up to their establishments.
So you've given me what the present shortage is.
Yeah.
What was the shortage before the COVID pandemic? Because I appreciate that the Ockenden review has increased the demand on midwives, rightly so, given the appalling cases we have had. But what I want to establish is, did we go into the pandemic with a shortage of midwives? Now, that should be fairly easy to answer.
Not the same level of shortage of midwives that we've got now. We had a smaller gap of midwives because the establishments were lower than they are now.
So what is the figure?
Sorry,
could you let me have the figures later if you haven't got them?
Figures,
It might be useful if we share the figures and put them in a table so that you get that comparative data from both providers. I think there's no issue with that at all.
Yeah.
But I think what Ali said is absolutely right, that the numbers were smaller pre-pandemic and pre-Ockenden. And having just done the Birth Rate Plus report, that's highlighted the extent of the gap that needs to be addressed. I think the really important point that Ali also made in there was, and we can't afford to lose, is probably the one around the pipeline in terms of new midwives. I know that UH&M, for example, have, and UHDB have recruited a whole load of newly qualified midwives, and they offer a fairly intense programme to get them up to speed and ready to fly, and to make sure that they do retain those staff. So we're working with both providers to make sure that that is taken forward.
But the issue is also you have to retain the staff you've already got. You might be recruiting, but you're also losing them. And so it'd be really useful, I think, if you could give those figures to Deborah and then the committee could have a look at them, because I think we need to look at what's happening with midwife numbers locally. We know what's happening nationally. They're pretty disastrous, really. But I just want to get an idea of how understaffed we are, whether it be pre-Ogden or post-Ogden.
Yeah, we'll do that for you. That's fine. No problem at all.
Thank you, Charlotte. I think also in terms of the responses, you touch on staff recruitment, and obviously Charlotte touches on retention. But I would encourage you to look at our previous conversation in terms of the primary care, which was a shortage of people, training, recruitment and retention. And I would suggest that actually social care has got the same problem, and most of the NHS has got the same problem. And we need to ensure that there is a better join-up, I think, across all areas in terms of career development, so that you flex people in and out of areas, so that we don't lose people to other systems or lose people full stop. So maybe you could take that away as well, because I think it is a strategic issue, and I don't think there has been sufficient scrutiny on this element, and I would like to see going forwards a workforce plan which probably picks up some of these issues, notwithstanding the current vacancies you've got. I accept that they're not your issue. I'm just making the strategic point, because I don't think there is enough being done on this to create that pathway. Steve, I think you indicated.
Thank you, Chair. Yes, for the reason you've just actually mentioned, and looking at the background reports to this, obviously we want a maternity unit back at Samuel Johnson. But it does seem to me it's a difficult case to argue for, actually, you know, this on-demand idea of midwives and that. And I just wonder how precarious the future was if it does come back, as let's wait till December, because the community impact reference in our report here says to be determined at a future date once final proposals are confirmed. But I don't know how you measure the community impact there, because how wide is the community, how narrow is the community? It just seems to me it's something that obviously we support locally, and I'm here as a district representative, but it's one that seems precarious. I'm not sure what argument should be putting forward for keeping it going when there's lots of other pressures, as we've heard, much wider than just our own authority. If that makes sense, that question, I appreciate a response. Thank you.
We need a system where Ali and I decide who's going to take the question. Do you want to take that, Ali? Or do you want me to go first? And then
you go first and I'll chip in.
No, that's fine. Yeah, and I think it's a really fair challenge, actually, because I think for us, our priority has been to do what we committed to doing pre-COVID, and that was keeping services running. And we're definitely trying to distinguish between two halves of a discussion. So there's two things going on here. One is about managing the impact of COVID and returning services to as near as we can from pre-COVID operating ways. But actually linked to that, and of course pre-COVID we were already doing the work that Ali very ably described around implementing continuity of care and choice and everything else. So we were already looking at what the operating model was, and the operating model there was always likely to be an on-demand one. But at the same time, it's about looking at the long-term sustainability of the service, particularly one, if you look at it in the context of, for example, the challenge around staffing. If you've got qualified midwives, what we don't want is a world where qualified midwives are standing in a unit, surplus to requirements because nobody's presented to deliver or to birth, depending on which language you use. Meanwhile, there's somebody in another unit somewhere else who could better utilise those skills. And I can confidently say, having been a midwife in my clinical life, that I remember doing births at, well, it was the Vic in those days, but the same unit. And I can also remember many an hour where, you know, I was surplus to requirements. So it really is a fine balance between making sure that we offer the right choice of services and one where we make best use of the limited midwifery resource that we've got. Ali, did you want to add to that?
Yeah, thank you. And I think it's just holding on to the evidence and the kind of the gold standard that we want to achieve, and there's absolutely no doubt that the delivery of that model is the one that we want to do, because the evidence tells us that that is the best and the safest model, particularly around continuity of care, and we get the best outcomes for women who are low risk. The bit that's flexible and uncertain is the framework that's wrapped around it. The Ockenden recommendations saying do this, some of the evidence and research that we're doing around the clinical negligence scheme for trusts, for example, Saving Babies' Lives Care bundles. There's all of the time there's new evidence coming out suggesting that you put something different in. So our providers, whilst they still have that aim and that vision and that choice element for families and women, it's within the context of needing to be ever changing. So it really is a balance.
Steve, do you want to come back?
Only briefly to say that it seems a little bit precarious still. It's uncertain at least, and obviously we need to look at the evidence and the outcomes and all the rest of it, and how the situation is in the future. So the long reply, which I am grateful for, is something I noted, as well as the sort of hesitancy at the beginning, which I always take as a compliment.
Absolutely. Thank you, Steve. And Angela.
Thank you, Chairman, and thank you, ladies, for your presentation. My question really is, coming back to basics and talking to mums and that, you know, that's given birth in UHNM. Have we any information of how many women have given birth there and would prefer to be giving birth at county? You know, is there any information regarding that? Because, you know, I know, right, with the increase of population, I just wondered whether there's been an increase in births from Stafford and Cannock area. Thank you.
I'll go with that. So we haven't seen an increase in births during the pandemic. If anything, they've dropped slightly. In terms of numbers, we've got the numbers of women who were choosing to give birth before the pandemic, before the unit closed. So we've got those numbers. And we have got some more recent numbers around women that may choose. We can get those numbers for you because we've started offering it in the hope that by the time they give birth, 'cause the advantage of pregnancy is that we've got 9 months to talk to women about what they might want to do. So women that are booking at the moment, we are having those conversations about birth choices and the fact that one of the freestanding birth units may be available for an on-demand birth. We've also got the numbers of women who meet the criteria, because there's a difference between wanting to give birth at the freestanding birth unit and then being actually within the criteria and low risk enough, because you need to be really low risk to give birth somewhere where there's no medical cover. So we've got those numbers. So those numbers are tiny, and then of those numbers, we've then got the option of women that they choose it. So we can give you some numbers, definitely. But because we're not offering at the moment for definite, we haven't obviously got any birth numbers that we can share because it's not available. Does that make sense? That was a bit of a waffle.
Yeah, thank you, Jay. So any information that you can give us on that, I would be grateful.
Yeah.
Thank you.
Yeah.
So just to be clear, given we're a county-wide scrutiny committee, I think we should obviously look at the county figures as well as the Samuel Johnson figures for balance. And second of all, I think what we're referring to is the pre-pandemic number, which is just a base starting point just to inform the discussion, and then what could have been done at those units if they had been open. I think that's what's being asked. I seem to reflect a number in my mind of about 100 at county, but roughly, but I may be massively wrong, so please don't take that as a start. Go on, Alison.
Yeah, The numbers are in the slides. So 93 women gave birth at County in the year, 252 at Samuel Johnson before the pandemic.
Thank you. Appreciate that. Let me move on to Janice Sylvester-Hall.
Thank you, Chair. I should just state Samuel Johnson happens to be in the county division that I represent, without making it too Lichfield-centric in that sense, because the question would apply to both of the FMBUs. With regards to the commitment about reopening in December, my question is about how that's communicated locally, and especially with the potential users of that service, and also as a member to make sure that any change to that is communicated. You'll probably appreciate there has been communications from concerned residents to make sure that the service isn't closing completely, and anything else that may also transpire that goes out amongst media locally as well. So it's really impressing upon the importance of making sure that any communication changes to that are communicated to us as members as well as locally, please.
Who's picking that one up?
We're looking at each other again.
Sorry, yeah.
Here. Yeah, no, I mean, we do have a strong, I absolutely agree, and I'm a local resident as well, so we're interested. You know, we absolutely agree, and we do have a strong communications plan, but also we have a strong maternity voices partnership. So we don't rely on them to be the only route out. Of course we don't, and we use our communications support to make sure that people are advised anytime there's any change, any decision made. So, for example, if there's been a delay in reinstating home birthing services, if there was a plan, if there had been a planned recommencement date for one of the FMBUs and we'd had to delay for staffing reasons, we've gone through all the normal communication channels on that. And then through the Maternity Voices partnership that we operate with our mums and families, and we do have various other communication channels. So not only do they come to our board, and it's meeting again this afternoon, and reps will be there, but we also have a very active Facebook group and a number of other ways in which we can communicate with our parents, so that we're not just telling the people in authority who want to know and need to know, but we're telling the people who ultimately are the users of the service and absolutely have to know what's available to them.
Janice?
Yeah, just say, again, just to reiterate, if there are any changes to the commitments that have been made today, that those are sent out also to members widely, so we can make sure that that accurate message is passed on.
They absolutely will be. Thank you.
And I think probably reading between the lines, it sounds like you've got a willing volunteer and champion in the County Council and within the local council, district or borough council, to act on your behalf. So maybe tying up with that member might be a worthwhile strategy. I think that was what I read between the lines of those conversations. Jill Hood.
Thank you.
Thank you, Chairman. My division is Stone Urban, and I speak to lots of mums who are expecting their baby. I speak to lots of midwives who work at the UHMN, and it concerns me greatly that the reports that I have are that the midwives there are literally on their knees. They're having to work extremely long hours. They're called upon to do extra duties when they're totally exhausted. This worries me greatly, and I know, speaking as a woman who's had 5 children, that it's essential that when you begin your labour with a midwife, you hope that that midwife is going to deliver your baby. And I know from reports that this is not always happening, and it becomes very distressing for these women. I would like to ask you if you can tell me how many midwives you've lost in the service since the pandemic. And my second question is, how are you making it attractive to men and women to come into the midwifery service? I know there's this ridiculous description as a sexy part of nursing, which I completely don't agree with. But I think midwifery, in my opinion, is an extremely important profession, and it is a vocation. It's not a part of nursing that you look at and think, oh yeah, I'll have a go at that when you've qualified. So if you could let me have those numbers, if it's possible today, I'd be very grateful. And thank you for your presentation.
Shall I go first, Sally, and then do you want to chip in? Yeah. So just a couple of things, really. So, and it's a minor detail, and of course, the short answer to your question is, yes, we can get those figures to you. Just to be absolutely clear, me and Ali and the team are not physically operating these services. They are operated by our providers. But we work very, very closely with our providers through the Maternity Transformation Programme, through the Local Maternity and Neonatal Service Board, to make sure we keep a finger on the pulse of exactly what's going on in terms of all of this. So we'll get those numbers, but we'll make sure we get the accurate numbers when we meet at the board this afternoon and get them over to you. I think just to pick up your point, and then perhaps to touch on something that came up earlier that overlaps, there is a significant employment group that happens, so a workforce group, and all of these kind of things. So things like employee numbers, how we become the employer of choice. And we, when I say we in that context, I mean we as an integrated care system, so working together in partnership. All of those things take place through that board. And I am sort of sitting here wondering if it might be helpful if Alex or one of my colleagues from the board were to come along and perhaps supplement some of what we've said with some information around what's happening from a workforce point of view. I'm going to shut up and hand over to Ali because I'm sure she wants to talk to you a little bit about continuity of care and other things in the context of your question.
Yeah, thanks, Helen. I think I just wanted to kind of thank you for your concern for the midwives, really, because there is absolutely no doubt that all of our midwives and obstetricians are under extreme pressure. You know, other services during the pandemic stopped doing things and closed doors and changed the way they did things, but our maternity services have never been able to close. Babies have carried on being born. And our midwives now are working under far more pressure now than they were ever at the beginning of the pandemic. For lots of different reasons. That part of the reason, some of the reasons are around how poorly COVID makes pregnant women, but also the fact that, you know, obviously from a staffing perspective, we have pregnant midwives who have had to isolate sooner, so they haven't been as available for work, and we've had midwives and obstetricians who have actually been poorly as well because of COVID. So that continues to really impact. So much so that both of our directors of midwifery wanted to come and be at this meeting today, but they're not there because they're supporting the pressures within the clinical services, and they are extreme today. So so that's just really to thank you for acknowledging that. We're all doing everything we can. So both of our services, both our providers are working around the retention of their staff. They've built in additional what we call preceptorship support. So newly qualified midwives have always had what's known as a preceptorship programme. So for that first 12 to 18 months of their practice, they get additional support to kind of to nurture them through that learning period. Additional support has been put in all of our maternity services, not just ours, but across the country, and that's to just try and nurture them through, because that first 18 months or so is extremely challenging and quite frightening. That's not to say it doesn't stop people leaving. Midwives do leave, and we know that they are leaving. And one of the things I will try and ask about for you is at what point in their career those midwives might have left during the pandemic, because what we've started to see is that younger, in inverted commas, midwives have started to leave rather than the older midwives. So there is something about retention. We'll see if we can get some information there. And yeah, continuity of carer. That model of working is known to, despite some of the contradicting information we get about continuity of care, we do know that evidence suggests that it's a far more resilient way for midwives to work, but it's that change to get us into that. And obviously we've got a model that it currently works in one way, and we've got to do a complete change to a different model, and we're within the context that we're in. So it's not just an overnight change. So yes, I think to sum it up, midwives are under extreme pressure. They're working additional shifts, they're working overtime, working long shifts, and it's not been easy for them.
Jill, did you want to come back?
No, thank you, Chairman.
Thank you. Just bearing in mind where we are on time, I've got one further question before we let you go, Heather and Alison, which relates to Ockenden. So I see the report very clearly says that in terms of the initial recommendations from Ockenden, that both trusts are almost fully compliant. I'll leave that wording there. That's not the purpose of the question, but I note you don't say fully compliant. And I don't know what almost means, but we'll leave that for a different day. I'm more interested to understand against the new additional 15 recommendations coming out of the latest Ockenden report, when the assurity will be given by the two boards that you are fully compliant with those additional recommendations, please. Just a date. I don't need a long narrative. Thanks.
Thanks, Chair. There isn't actually a date for that. So what our providers have done is they're benchmarking against the recommendations. The recommendations are currently being considered by an expert advisory group for the National Maternity Transformation Programme, because we are expecting another report from East Kent to be in September, October. So what they don't want us to do is set up a whole assurance factory on the second Ockenden, knowing that there's another report due to be published very shortly. So our providers are benchmarking against those actions, but the actual assurance at the moment, we don't know what that's going to look like until the autumn.
Is that the position across the whole of the country? Because that seems interesting that we don't take the knowledge we have and use it, because it's always going to be permanently changing with new models of care and other concerns from other parts of the country. So I am surprised that we haven't done I was led to believe that we'd done a rough cut across the two trusts in terms of assurance.
Yeah, based on the first 7, the original 7 actions from the original Ockenden, which is the bit where you said we're all almost. So the bits that are missing for that are a couple of audits results missing and some minor guidelines. That's why it says almost. But so those initial 7 that we've got assurance that they're all met. The 15 are the ones that we're just benchmarking against.
Heather, I notice you want to come in.
Yeah, just being polite, really. So I think just to reassure you, Alison's absolutely right, but that doesn't mean that we're not doing anything. So we meet on a monthly basis as a local maternity board. Ockenden is right up there on our agenda, as you'd expect, and we are working with both of our main providers and all of our providers in terms of ensuring that they have got Ockenden at the forefront of the minds, as have we in every aspect of the work that we do with the maternity transformation teams.
Thank you both. I'm led to believe that we've got this on the committee's agenda for October, and we will no doubt have a further conversation in October, albeit I think in terms of this committee giving any assurance, I don't think we've been given the assurance to be able to provide that to our residents. So I would hope in October that you factor that into the discussion. I think I will leave that conversation where it sits. We also have on our October committee the discussion about careers and staffing, and I think Jill Hood's questioning probably does make sense as a point that we can't forget the impact on the staff within the NHS. On that basis, ladies, thank you for your input to the debates this morning. I think everyone's found that very useful. I particularly liked the commitment to the services and to the services reopening and to making sure that that is communicated with all relevant parties, particularly parents-to-be, and that there is that focus in on staffing and careers. So thank you. You're welcome to stay with us. You're welcome to leave, but I appreciate your input to this morning's discussions.
Thank you.
Thank you.
So on that basis, let's move on to item number 7, which is Staffordshire Health Watch update. So before we start, I'd like just to welcome Support Staffordshire to their new role and to wish them the best with hearing all residents' voices across the county on both health and care issues. I would just like to make one point, which is that this committee is as a scrutiniser of the work of of the Health Watch contract. So we are both a partner in terms of communication and collaboration, but also it is our ultimate job to scrutinise the work of the Health Watch Committee as well. And we shouldn't mix those. We shouldn't miss those two roles. Let me hand over to Baz, I think, who is Baz Tazeen, and you're going to just take us through in 5 minutes just a summary of your report, please. We have the presentation, thank you.
Yeah, thank you. Yeah, it's Baz Therese, thank you very much. Okay, so today I'll be presenting an update on Health Watch Staffordshire.
Sorry, can I just ask you to move the microphone just a tad closer for people like me who are a bit hard of hearing and too proud to use a loop?
That's okay, is that any better? Thank you very much. Yeah, so today I'll be presenting an update on Health Watch Staffordshire and take the report as submitted as read. I will be presenting on 6 slides to highlight key areas of this report to the committee and take any questions and answers at the end. So as of the 1st of April 2022, Support Staffordshire were awarded a 3-year contract to run a new Health Watch in Staffordshire. So our vision is to help people get the best out of their local health and social care services, both to improve them today and helping to shape them for tomorrow. As part of our mobilisation of Health Watch Staffordshire, an independent Health Watch committee has been established, which holds delegating decision-making powers to set the Health Watch agenda. This will consist of 4 unpaid Support Staffordshire trustees and at least 2 independent lay members who will form part of this committee. The Health Watch team itself will consist of a Health Watch manager, which is myself, and there will be 4 engagement officers covering the southwest, the southeast, north, and a social care focused post. This will give good coverage across Staffordshire. We will and all 4 posts will be at 30 hours per week. There will also be 1 project worker data analyst at 22.5 hours. We have been through a process of 2P and recruitment, and all available posts in the new Health Watch team are now in place. The engagement officers are in the process of reaching out to existing volunteers and to give them an opportunity to continue as volunteers. There will be a process of induction and training within Support Staffordshire. So, Health Watch approach and priorities for year 1. We will be having a focus on diversifying our volunteers, and we will include those from seldom heard groups, such as the LGBTQI+, the BAME community, so the Black, Asian, minority ethnic groups. We'll also be, and we have reached out already to expert citizens, so these are people with lived experience, who are sometimes can be from backgrounds such as homeless communities, mental health, substance misuse, who have gone on to become functioning members of society and now giving back. Further, we have had meetings with NHS partners about student nurse placements, and we will be reaching out to student social worker placements as well. Health Watch will be working more collaboratively with key partners and stakeholders in the pursuit of best practice by working more closely with voluntary community social enterprise, private and public sectors to ensure high quality care is based on patient and resident feedback. Health Watch will contribute to the local voice and strategy of the Health and Wellbeing Board, the integrated care systems, and commissioners across the health and social care services. These will also include the Health Watch Stoke-on-Trent and Support Staffordshire social prescribers. Health Watch Staffordshire has been working with Health Watch England through ongoing meetings and communication to standardise the web page to be in line with Health Watch England template, to share relevant data for deeper impact within GDPR. Health Watch will be working more closely with Staffordshire Observatory, which is a highly skilled team of research and data analysts that reside within a wider strategic team at the Staffordshire County Council and NHS partners. Further, we will be building on this through our intelligence gathering, through the Healthwatch Intelligence Network being established to engage multiple platforms for gathering health and social care data. This will include the voluntary community social enterprise health communities, support Staffordshire voluntary community social enterprise locality forums and relevant Staffordshire events, and maximise collaboration with the PPGs, patient participation groups. Healthwatch has a grant fund allocated of £15,000 per year to help support groups from hard to reach, seldom heard and rurality to increase the public voice and patient feedback in areas that may otherwise be hard to reach. This could be for the cost of setting up relevant groups or money offered to existing groups for engagement offers to have to use that and their time. So as part of Healthwatch, we will be reviewing our enter and view statutory powers and how to best use this. To add value to its use, we will be working closely with statutory partners such as the quality and safety teams at Staffordshire County Council and the NHS. We will share relevant data with partners to avoid duplication and add most value and impact. So for the Healthwatch Deep Dive focal investigations, we do have a fairly long list of potential focal investigations, 12 to be precise. This came about from the public feedback during the pandemic and due to its current and ongoing impact. We will be working with partners and public to start the selection of around 3 or 4 areas for a more in-depth work. Currently, the 4 possibly being highlighted are root causes of good and poor teenage mental well-being, health outcomes when you've been in care as a child, older people accessing services, seldom heard groups including the LGBTQ. This could also include the BAME, women's services and men's services, patient resident in the health and care system. A running theme throughout this will be about rurality and safeguarding. As we do these deeper dives, we will have a focus on the, however, for more from this list will be selected in years 2 and 3 potentially. So if other things are coming up from this list of 12, they could be looked at again in the coming years. Healthwatch will also be getting feedback in the round and investigating on other issues and giving feedback and recommendations. We will be communicating our role to the public and our outcomes. We will be doing this through face-to-face, at events, the Healthwatch website and social media followers. Healthwatch currently has a social media reach of 3,651 following us through Facebook, Instagram and Twitter. We are looking at expanding this to other platforms in the near future. As part of best practice, Healthwatch will be supporting the health and social care partners to keep information, advice and guidance up to date and relevant. Healthwatch will be engaging with statutory partners, organisations and boards to present our findings and influence systems change to help ensure that the independent resident voice is central to local health and social care services. Thank you.
Thank you for that summary of a useful paper. I'm going to open the floor to Anne Edgeler.
Thank you very much, Bads, for your presentation. My question really is, you're talking about mental health and looking at teenage mental health, you know, young people's mental health. Have you actually, I remember going to a meeting to do with Healthwatch, and this was ladies that had just given birth, and they were really suffering with mental health problems, and of course that has an impact then on the children's mental health. So, you know, will you be looking at that as well when you're in your investigations? Thank you.
Yeah, we'll look at all the aspects that come out. So let's just say we're looking at women's services and that comes out as a theme. Then we can look at doing those as deeper dives in the round. So there'll be things that'll be highlighted and then we'll be looking at working with our partners to see how we can give more focus in those areas.
Charlotte.
Baz, a colleague of mine, in fact a resident of Leek, tried to contact you. She'd had an appalling situation where a cataract operation went wrong and she wanted to share that experience with you. Nowhere could she find how to contact you. She contacted me on the basis that I might know how to contact you. So I said I would raise it with you today. Because it seems to me that you say in your presentation that you want to hear feedback from residents, but you don't make it very easy for people to contact you. So what are you doing about that? And how do you expect people to contact you?
I appreciate it, and that's unfortunate, so I do apologise if that's happened. As mentioned, we have been through a process of 2P. There was a period of time when things were being ported over. I'm not saying excuses at all, but we have been through a process of making sure we go back through everything and see any feedback coming through and then responding. And now, like mentioned in this, we have finally got a full team now who can engage with the public. So there was a period of time where there wasn't anybody physically available and systems weren't in process. It did, unfortunately, I'm hoping that wasn't the case, that it was missed in that time, but it may have been, and I can't 100% say that was the case. However, that said, I will take note of that and we will ensure that doesn't happen.
So the answer to my question is, how do people contact you now?
Yeah, at the moment we have got our inquiries email through our website, so anybody can send us an email through that. We have got contact numbers that are available on the website, so we are working to make sure people can use those numbers and they're working appropriately. There was some issues before with porting numbers over, especially the free number. And then we have got our social media, so through Facebook, Instagram or Twitter, and now we have got a lead that's focusing on seeing what's coming through on that.
Because her experience was she was holding on to a number that wasn't answering. And, you know, given that she has eye problems, she's not going to be using the website very much. You know, it is very dispiriting when someone who has a very significant problem that she wants to talk to you about, she will be going to the Health Ombudsman, but that will obviously take possibly months. And it is important because it is something that I think that anyone having a cataract operation would be very concerned about because she's been left with very diminished sight as a result. So, so you're telling me that the telephone numbers on the website now work?
Yeah, we are in the process of getting that working 100%. There has been some problems with it. Unfortunately, the previous provider who had the contract have been trying to get it ported over. We've been working with them, but the hold-up had been with the actual organised company itself that holds the number. So we are still in the process of testing it, and there's been hit and miss on that one.
Can I just, I sense some of the frustration. Can I make a sort of wider suggestion? Can you look to create a contact point for all councillors, districts, boroughs, county councillors, and then send them the stuff? So if there's a specific contact in Leek or Stafford or someone, can you personalise it so that it's clear and maybe a point of escalation, which I guess is yourself, just so that we don't lose the opportunity to hear residents' voices and don't lose the opportunity to feed into the work, the vital work that you guys are doing. I think it's an important point. Steve Norman.
Thank you, Chair. It's really about training for Health Watch members, lay members and others. Anybody who read the report on the Mid-Staff's inquiry will see how Health Watch's predecessor let the community down, and certainly this Scrutiny Chair, the predecessor, let the community down in their lack of scrutiny of Mid-Staff's Hospital. So my question was really is, can I be assured there is training on scrutiny for Health Watch members and lay members and volunteers, really, asking open questions and that sort of thing. That's so important, not to be intimidated by somebody with certain qualifications, but asking the simple questions on behalf of residents. So I'd like to be assured, if not, I'm happy to take credit for giving you a great idea of encouraging training for lay preachers and others as well, lay members and head preachers as well, lay members and others as well. Thank you, Chair.
Yeah, definitely. One, noted, yes, I will take that on board, and training is definitely relevant. And two, we have spoken to somebody, one of the expert citizens who used to deliver training around enter and view, who has said they are willing to offer that again for free. So both, yes.
Just two things that come from that. I mean, I guess the question is, how do we know that that's effective? And second of all, I'll just leave that with you as a question, not for answering today, maybe for you to think about. And second of all, there is an open invite for Health Watch to feed into this committee and to be represented at this committee, obviously as a non-voting member. And as you grow that understanding of Staffordshire's voice, I would be encouraged if you would take that up, please. Jill Hood.
Thank you, Chairman. Thank you for your presentation. I would like to ask why in my division of Stone Urban, you're almost non-existent. Your advertising campaign hasn't reached our town. I have advised a few residents to get in touch with you. I'm wondering now, we have quite a large contingency of Ukrainians who've come to our town, how I direct them to you. And my third question is, how do you level your success? I know that people are going to ask you in particular about the woefully inadequate mental health services and how they're finding the first of all, how difficult it is to access an appointment with a mental health agency. Secondly, the total dissatisfaction with the mental health agency. So when you deal with these people, when they come to you, how do you quantify your success? How do you actually, will you feed back your success to us for the amount of people who've come to you? Thank you.
Okay, yeah, thank you for that. Yeah, we are looking at how we can better improve the reach, which is why one of the things we have been working on with partners about rurality. One of the things we have got an advantage with Support Staffordshire being the provider is that they do have a good reach with a lot of their volunteers and a lot of their locality officers and the social prescribers who are already based in certain key places. So we're going to be using those as helping us to get that extra feedback. And as for, with like you mentioned, with the Ukrainians, again, we are working on opening up as many opportunities to help people to make contact with us. And that could be through anybody here, and that could be with anybody with any services feeding that information back to us, and then we will ensure we'll get out there and meet those people and get the feedback.
Thank you. And just following up, sorry, Jill, do you want to come back?
No, I don't. Thank you, Chairman.
So just following up the response you gave there, I note in paragraph 19 that you talk about you'll be creating those performance measures and monitoring for the contract. I'd be grateful once you've got to a finalised set of metrics, if you could just circulate those in writing to us so that we can circulate those around committee, if only for visibility and understanding from that place.
Yeah, okay. Yeah.
Keith Flander.
Thank you, Chair. Just a couple of points, really. I think you've already answered the one about how you're going to try and engage with the voluntary community groups in more detail than perhaps has been the case in the past. Not sure how you're going to increase rurality, or whatever that might mean. Obviously, from the moorlands, we are mostly a rural environment, and we do differ from the boroughs and things like that. So I'd be very interested to know what you might be able to do. That perhaps that could be part of your presentation next time round. And then how are you going to try and fit into the new integrated board, partnership and all that sort of side of restructuring on that side? How are you going to feed in your findings into something that will then make sense back through the process, both with this committee but also directly with the new integrated board? I don't know whether through the partnership or whatever else. I think the lady's just gone, unfortunately, but there you go. I don't know whether what you're intending to do with that. That was all. Okay. Thank you.
Yeah, absolutely. Yeah, one we will be looking at. The rurality will be an interesting one. We are giving it a focus. We have got 2 engagement workers that are job sharing to give more coverage across the moorlands, because it's quite a big area. So that's one area we're trying to tackle. And what you said about sharing information, that's going to be one of our key aspects on let's just say, feeding back on a more regular basis to the partners. So what feedback we get, we're going to try to do monthly reports where possible and give those to like the Integrated Care Board or to Stafford County Council, and again back to any other boards. So as much data sharing as possible going on a more regular basis and giving those updates to help increase that.
Chair, I just wondered if we could maybe sometime between now and the next meeting you come up with a bit more of a structure to how that feedback's going to be put forward through the whole process. I just think that might be something that that we're here to scrutinise how that might work and the regularity of it and everything else. I think that's something we might need to monitor along with how we're going to measure what they're trying to achieve. Thank you.
So just let's ask that of Baz. When are you going to come up with the performance metrics?
Yeah.
Hi, Chair, if I may, Keith Lusscombe, Strategic Policy and Partnership Manager and lead for the contract from the council side. We're currently kind of firming up those final kind of metrics and that whole kind of performance monitoring approach. We should be able to share something, I'd imagine, around kind of late July, August time, certainly as a high level across all of that. Obviously, that won't be full reporting, as it were, but at least across the kind of the key areas we're looking at, if that's okay.
Brilliant, thank you, that's really clear. So I would suggest that we pick up Keith's point at the same stage, if we can, please, because that seems to be a subset underneath that. I accept it may take a bit longer, but it'd be useful to do that together. Does that answer your point, Keith? Thank you. Okay, on that basis, I'm seeing no one else indicating. So, Baz, I think we should welcome you to your new role and the work that you're doing. We should wish you good luck, and we look forward to the ongoing progress of hearing residents' voices and just seeing what that performance monitoring looks like. So thank you for coming this morning. You're welcome to stay, you're welcome to go. Otherwise, thank you for that. Can we move on to item number 8, which is district and borough activity? Let me just make one point, and I think it's really important. Can I encourage all members who are either district reps or county reps on local district and borough scrutiny boards to read the terms of reference, because they probably give you a very good clue, because they're the terms of reference about what should be scrutinised where. And I would encourage, if you think that you are scrutinising something which is a county-based issue, that you either get your officers at a district or borough level to speak to Debs, or alternatively pick up the phone to Debs as well. She'll give you a very good steer. Take that to mean that some of you might be closing on areas that are the county council's responsibility. And I think Steve has very eloquently enunciated this morning, it is really important we are clear on who is scrutinising what, and we don't duplicate or leave a gap between us all. So if you are in doubt, please pick up the phone and have the conversation, or ask your officers to do so. I would also ask county reps on those district and borough boards, if you are concerned by what is being on the agenda, that you raise that as well with Debs. So let me just move on to a note of the report. We won't go through the detail, but there have been some where there's been a meeting, but it isn't recorded in the paperwork. Is there anyone who would like to? Is there anyone? Philippa.
Thank you. We had our first meeting, of which I was chair, previously chaired by Martin Buttery, who I believe has been to your meetings before. We had a good introduction from our head of services, which explained our role at District Council and what we should and shouldn't be looking at. We've come out of our meeting with a task and finish group that will be focusing on housing, which will be meeting in a few weeks' time, and hope to bring something back on that for you. We're also looking at the Cannock Chase CAM project with a focus on obesity, and how the Cannock Chase CAM project in our area is actually being successful or not, and how people are using the app. Thank you.
Perfect, thank you. Just for clarity, I'm told you're actually called Pip rather than Philippa, and it's... Okay, that's fine, thank you. Is anyone else? Steve.
Yes, just to say that there's been a briefing paper, Lichfield District, on food safety, and that's an issue that I predict we'll be raising at the Scrutiny Committee. The thing is that we've only got one Scrutiny Committee now, at least until May, where we're trying for 2 years. with one scrutiny committee. And for that reason, the information on your paper there isn't quite correct, and I did warn Janice Sylvester Hall that I've been mentioning her. She's not your representative on the District Council Scrutiny Committee. She's a full member of the Scrutiny Committee of the District Council with a different hat on. And as I understand it, and I've checked with an email this morning, Councillor Mark Wilcox is our liaison between yourselves, county that is, and the district. So if that goes against the regulations, very happy to take that back and try and get it sorted. But it makes it more complicated with only having the one scrutiny committee there.
Okay, I would just like to take that conversation outside because I'm not fully understood and I'm just mindful of time,
right.
but happy to address that either at the end of the meeting or alternatively separately, just so that I can pick it up with the relevant people. It's probably into the detail. Do we have anyone?
Well, sorry, just on what you've actually said at the beginning of the introduction to this, because we've been waiting for a Burwood Health Centre now since 2008. And I did see in 2014, the Scrutiny Support Manager at the county advised that it was a locality issue that should be dealt with via the joint code of conduct at local level. So you've got Samuel Johnson, which is Lichfield District. You've got the George Mine Centre, which is Lichfield District, not Tamworth, by the way. And yet the questions about Burwood Health Centre isn't allowed at this committee. If I could have some clarification on that at some point, if not today, that would be helpful, because as you say, you've tried to set out the guidance, you made point to the terms of reference. That would be helpful. Thank you, Chair.
Absolutely understand that and absolutely agree with that, in as much as I think that was what I indicated at the outset of this, which is if there is gaps that we need just to talk through to make sure we're aligned, absolutely welcome to do that. Happy to do that offline. Is there anyone else indicating in terms of filling any missing gaps off here? No. So on that basis, let me swiftly move on to the work programme, which is item number 9. And then we will go into closed session at the end of this. So, you have in front of you, as part of the works programme, a whole variety of things. It's quite complex in terms of the work programme. We have, I think, this morning agreed to add dentistry to the March meeting. We have talked about KPIs, which would naturally come back to the September meeting. We previously talked about a need to do a review of the critical incident that was called at UH&M in terms of the lessons learned, and I suggest we bring that back to the August meeting. And I would suggest that August might be timely for the winter flu campaign discussion as well. Does anyone else have anything that is burning and they feel isn't covered by the works programme? Janice, do you want to say anything?
That was a very subtle cue there. I am keeping an eye on the time because I did mention to you earlier on I do need to disappear early from this meeting. So if I could, Chair, take a couple of minutes just to mention about the Women's Health Working Group that was part of that. We had a meeting on the 13th of June, and I'd like to thank Anna Angela, Barbara Hughes and Patricia Ackroyd for attending that, and ably supported by Deb. That was born out of the fact that we'd had the paper that was produced by the Department of Health and Social Care, which looked at the vision statement for England's women's health strategy. And we met to be able to try and look at how that is going to present itself within Staffordshire, and also tried to, with those people who were assembled, to cover the county in its entirety. And it was a useful conversation point to begin with, to be able to look at how we can take out some of the information from that report, which highlighted certain things in particular. Bearing in mind that we're looking at 51% of the population here, in terms of whether or not some of that information was relevant to Staffordshire is one of the things that we need to look at. So it flagged up things like, are females in particular being listened to when they go to see their GP to start off with, and then whatever else as far as treatment concerned. And also geographically, if there's any issues within the county, any ethnicity factors that we need to be aware of. But then going on to things like how women's services are actually supported. So with regards to the staff that's available, for those that are particularly women-centric ailments. So whether we're looking at a full list that we put together of issues that specifically affect only females, but also ones that maybe anecdotally we're aware of that are treated differently. For example, such as autism diagnosis, which can happen later in life. So there is a list that's been put together. We're looking at how that's impacting specifically within Staffordshire. And the plan is next that we will meet again to look at gathering what type of information is going to help support some of the questions that we need to have answered by the professionals that are most in a position to do so. And that's looking at happening in the next few weeks. So at the moment, those notes that went from the first meeting out to the attendees for comment on, and I would say if there's anybody else in the meantime that wants to input anything in particular to those, then they're more than welcome to do so. And we're hoping then to be able to put together a time when we can put it on the work programme in particular to be able to go through some of those topics in more detail. That's where we're at the moment with that one, Chair.
Janice, thank you. Thank you for the work that you and the Working Party are doing, and thank you for that update. Much appreciated.
No problem.
Okay, so I think that probably gives us a summary in terms of the work programme. I was remiss in not thanking Councillor Edgeler for chairing a very helpful Healthy Communities workshop, and I know there was a number of you who attended that, but we will bring the notes to that coming forwards and encourage you to roll that through. But let me hand over to Anne in the meantime.
Thank you very much, Chairman, and thank you, Janice, for that. I really enjoyed that meeting we had, and carry on with the good work. Yes, we had a good meeting about the health workshop. It was very positive. Actually, a lot of outcome came out of it. Not outcome, a lot of interest and different things came out of it. We were hoping to bring something, I think, in August, but I think it's, with Chairman's permission, it'll probably be September now. So we'll bring more feedback on that workshop in September, if that's okay with the Chairman and the committee. Thank you.
Thank you, Councillor Edgeler. I think that is appropriate. No point in bringing it prematurely if it's not ready. Okay, so I think that probably brings a close to the formal part of today's meeting. We're about to go into closed session. So thank you for your involvement this morning. I'm just going to wait and get a signal. I've got to read this apparently. It says, I'm going to move, which means we need to vote on it, that the public be excluded from the meeting for the following item of business, which involve the likely disclosure of exempt information as defined in the paragraphs Part 1 of the Schedule 12A Local Government Act 1972, as amended, indicated below. Are we in agreement? Thank you. Just let's wait and get the sign off that we are no longer in beaming.